Good evening everyone. أنا في الأول هقدم الدكتور كارلوس بالعربي علشان إحنا الكافيه بتاعنا من الأول in Arabic وهو سمح لنا إن إحنا نعمل introduction ده بالعربي وده سبيشال ابيسود لبرنامج القهوة وإن شاء الله بإذن الله يبقى برنامج مفيد وحلقة مفيدة لينا كلنا. وهسيب بقى الانترودكشن بالانجلش للدكتور كارلوس من صديقي الدكتور طارق علشان هو في يوم من الايام كان الفيلو مع الدكتور ماتيو في الايمو. دكتور طارق.
It was really a great days. I spent a very short fellowship with Dr. Mateo in Barcelona at IMO at 2017. It was really highly informative and highly educative. Not only because Dr. Mateo is one of the most talented veterinary surgeons all over the world, but he has something different I noticed during my stay with Dr. Mateo. He has a rationale for everything he's doing in all the steps of the treatment. He has also a rationale by telling you why he doing this step like this and why. So I advise all my veterinary colleagues who watch us to ask freely about any queries, about any tips or tricks in the treatment. He's very helpful, very supportive, and I'm so happy to meet him again after this long time.
We are happy to be with us, Dr. Mateo. Ahmed, if you have some words to starting the discussion.
I'm just so excited that Dr. Mateo is with us today, and and a very hot topic of high myopes and with none other than the king of high myopes in Europe and the world. So we're so excited to hear from him and to talk about all our questions about it. And let's start without delay.
Dr. Mateo, let's start the show.
Thank you very much. You're so kind. I'm very happy to be here to speak about myopes, and have been a part of my life. I started with macro translocation 20 years ago, and was amazing thing. Then please stop me when you want, because surgery in high myopia is so broad. We can stay here for weeks. Speaking about tricks and all of this stuff. Now let me share my screen because I prepare a presentation for you. Okay, you can see now my screen? You see my screen?
No, until now I didn't see until now, Dr. Mateo. Just click and
let me show you this.
Yes, perfect.
And
perfect. We
better
see
now? Okay.
No.
Then,
Dr. Mateo, just sharing the entire screen, not the application window. Just close the share now. Close the share now.
I close the share now. Okay.
Yes.
Stop
And share again, but choose entire screen. Not application window.
Let me try to do the same. Share screen and okay. And this one is like this.
Display? No. We need to you choose the application window. Yes. No. When you stop share again, and I will go with you step by step. Close the share again.
Stop share screen. Okay.
And share screen. You have a three choice. Entire screen.
I have three choice. Hey.
Yes. Make us with the first choice. Entire screen. First choice, yes.
No, there is the screen.
Just click on share.
There is only one. There is a share screen. There is nothing more.
You can press it now. You will another drop down menu.
Now you have
another screen application window or the entire background or entire desktop. Click on the entire desktop.
Yeah, but I do it and okay. Let me try.
Click in the picture on the picture of the entire desktop.
And you see it now?
Disappear when you.
It's so rare because we did it before and it was wonderful. Yeah.
That always happens.
Yeah.
don't play the presentation in full screen. Just yes.
Okay, let's stop again. I'm stopping again.
No. You are now just now play the presentation without full screen.
Stop screen. Okay, and then I share screen again, and I have a share screen, and then screen 1, screen 2, screen 3. But you know, I have this one, these two, and okay, screen, and then
Yes.
you see now?
Yes. We now on.
Yes.
We now on. Yes, we are now on.
You see it?
You see it now. Yes.
Okay, perfect.
Yes, that's a high myope.
Okay, yeah. It's a high myop. Yes. It's a draw that you have two different problems in high myopia. You have the peripheral problems, that are related to the posterior vitreous base, and we were commenting that, posterior vitreous base in high myopic is very irregular. It's not as regular as in metropic eyes. You have posterior extensions of these, posterior vitreous base that makes that in some cases you have a large breaks, posterior breaks, even the arcades breaks, and you have the problem of the posterior staphyloma and the deformation of the posterior eye wall. And you have very different clinical pictures. You see upper left, you see a typical, high myop with a giant retinal break. You see multiple breaks up and right. You see multiple breaks down and left, and even posterior breaks with posterior attachment. I don't know if you can see my pointer here with posterior attachments of the posterior hyaloid. You have these posterior breaks and retinal detachment. One of the typical cases when we speak about high myopes is the giant retinal tears. Let me tell you, giant retinal tears is for eyes that have, let's say, 6, 7, 8 diopters in myopia. These are not usually high myops, and middle high myops, Let me tell you 2 tricks about this. Let me confess that I continue to use buckles in these cases. I use buckles in my retinal detachments, and it will take a lot of hours to define this. But these are typical giant retinal
vitrectomies.
Can you see it?
Buckle plus vitrectomy, or
absolutely. I do. In this case, is a phakic patient. He's 32 years old, myop. It was 9 diopters in myopia. As you can see here, is no posterior staphyloma. I put my buckle in. Yeah, okay. I do buccal vitrectomy. Yes, absolutely.
So what's the rationale for this?
The rationale is that when you have the retinal detachment, the retina shrinks. And then when you try to put the retina again in its place to the anterior circumference, then the retina is stretched because it has some kind of, stretch, some shrinkage.
But if you do a buckle, that's what I always see. I noticed that that it is used a lot in Europe and also in Egypt.
Sure.
If you put a buckle for the retina to relax on it, the same wall or the same circumference of wall or the same surface area of the wall is still there. So the retina is going to be flat on a billowed wall, then go back again over the buckle, then go back again. It is the same surface.
Absolutely not, because you are putting the buckle and then you are putting the retina in a lower, in a shorter circumference. And remember, you are not going to remove all the vitreous base. Then you have remaining tractions there. Then, at the end, we can discuss this, but, my experience is that when you do this, redetaching is so rare. But at the end, if you are happy with your results, and be careful, because the places where you have to be more careful is in the angles of the giant retinal break. In the angles, you have some traction of the remaining vitreous. Then but at the end, it's your decision about to place a buckle or not. But I still there, and be careful. I don't like to lose my time in the OR. Then my experience over 30 years is that a buckle, for me, in my opinion, is better to avoid the buckle. But
Dr. Matei, you do not lose time in the operative room because you insert the buckle in 5 minutes.
No, not in 5. Not in 5, but in 12.
See?
Not in 5, but in 12.
You timed it.
Yeah. Yeah. This is between 12 and 15, depending the assistant. But it's that easy. So easy to place a buckle. And then on the contrary, on the other side, let me tell you, radical vitrectomy is by far more complex. You may produce breaks, you have to indent, and I'm going to explain you how to avoid some problems with this.
Is it almost 360-degree buckle?
Absolutely. Yeah. I put 240 band. It is 2 millimeters wide, and I put my buckle there. Yeah.
And it's 9 millimeters from the limbus, right?
It depends on. Look at this. The trick of the buckles in general.
Yes.
Pseudophakic patients that are mainly emetropic put the buckle just 1 or 2 millimeters behind the insertion of the muscles. Okay. In high myopes, put the posterior stitch of the buckle just 1 millimeter in front of the vortex vein. This is clearly different. In high myopes, as I told you, the vitreous base is more posterior and more irregular. In emetropic pseudophakic patients, the breaks are small and they are anterior. Then don't go very posterior with the buckles in emetropic eyes, in emetropic pseudophakic eyes. But in high myopes, always be as posterior as possible. Never step on the vortex veins. Never, ever. Okay? Because try to avoid the choroidals. Okay, let me show you the trick I want to show you apart from the buckle that we can discuss this for years. There are people discussing this for years. Then the first thing I do is to put, after finishing my, let's say, core extended vitrectomy, the first thing I do is put air. And why do I, partial air exchange? Because I want to, broaden, my visual field, as you will see here now. Oh, excuse me. This is the next case. Okay, look at this. I do my vitrectomy and then partial air exchange, and then I'm aspirating part of the subretinal fluid, and then I'm going to put perfluorocarbon liquid, not to the break, just posterior to this. And then I use a maneuver that I call, sandwich technique. Air up, perfluorocarbon down. Air up, perfluorocarbon liquid. Then am I squeezing the subretinal fluid to the break? What's the advantage? First, you won't have slippage after this. Second, you won't have any bubble entering the subretinal space. You attach the anterior retina, you go with perfluorocarbon liquid, squeezing the fluid, you stay there, and at the end, you remove.
So you tell us that you usually do direct PFC air exchange, not direct PFC silicon exchange in giant retinal.
I try never use silicone oil in giant retinal breaks. I don't use it. I use it in kids. In Stickler syndrome, for example, that is a very difficult cases. But normal cases, myop cases with a giant retinal tear for something years old.
You found that this technique of PFC fluid air make the giant retinal tear little chance for slippage.
No, because when you put air in the anterior part, you are avoiding that the fluid that comes up with perfluorocarbon liquid accumulates in the upper part of the retina. You know what produces slippage? Slippage is produced.
Yes.
Slippage is produced
there is fluid under the retina
Of
in the
course.
mid-peripheral area.
No, you're great. Absolutely. Is this the problem? You know, but if you do the sandwich technique, air for carbon liquid, you
Air,
stay
but-
there, aspirate more fluid.
But not full air fill, half air fill.
No.
and
Just
some-
to the break. Just to the break.
Just
Just
to-
to the break.
Yeah.
And then at the end, you know, when you are just in the border, then you can put perfluorocarbon liquid to the ora serrata, no problem, because you are not going to have any bubble under the retina because all the retina is attached. Then you don't have open doors in the borders. Then you are going to remove as much as fluid as possible. Remember, you won't remove all subretinal fluid. You try to remove as much as possible. Then
So you
So the sandwich technique is you aspirate the fluid down to the break and stop at the break, and
Exactly.
then inject
Perfluorocarbon liquid.
while your FAX is on, the air is on. You don't stop it.
I
And
don't
you-
stop it
Yes, and you inject over the disc until it squeezes
until the
out
break.
the
A
subretinal
little
fluid.
bit posterior to the break.
Okay.
A little bit posterior to the break. Okay.
And you are putting on air, completing the rest of surgery on air, or
No.
just switch?
Wait.
Oh.
You finish your vitrectomy, right? You finish your vitrectomy.
Yes.
Okay, air to the break, perfluorocarbon liquid to the break. Then you aspirate, and then you clean the anterior fluid, and then you can put more perfluorocarbon liquid, and then you are squeezing the subretinal fluid because of the air and the perfluorocarbon liquid. Then you are reducing, the fluid under the retina. And then you put more perfluorocarbon liquid. You don't care to overpass, the break because you have no way. First, you are under air. You won't have, a perfluorocarbon liquid bubbles to the the water stream because you are under air. You don't have, these bubbles to enter in the subretinal space, and you will attach all the retina. And then at the end, and the perfluorocarbon liquid, I do the laser.
You complete your vitrectomy under air.
Yeah, I do. Yeah. Because you see more periphery, and then the retina is attached, and then the retina is stable, and you are pressing your retina towards the wall. The retina is not mobile now because you press with the air, and you see. If you are used to see it, it's very easy to see it. You see like a gel, over the retina. And you go there, yes, you trim it. Don't try to remove all the vitreous. You are going to promote more breaks. Then you remove this vitreous, and that's done.
And you put
This is
gas.
a question to
I put gas, yeah.
What kind of gas?
SF6 20%.
SF6
SF6 20%. I almost never use C3F8.
Dr.
too long.
Matteo, you do this technique especially when you combine the buccal with a vitrectomy, or you can do it?
No. Well, I combine buccal and vitrectomy in all of my retinal detachment cases. Then
All of them?
in all cases, yeah. When I do vitrectomy, I combine them. Yeah.
Oh, okay, this is not our point of discussion here. Combine buck or vitrectomy, but
I know.
This special technique of sandwich, for me,
That's
it's
a plus.
very
It's
perfect.
for the قهوة.
Right.
It's perfect.
Is the best way to remove as much as subretinal fluid as possible. But you can ask me, okay, but imagine that you did it perfect. But at the end, you are going down with the, the air exchange, final air exchange, and you see that you have some fluid going down. Yeah. Let me tell you, the trick is when I began to remove the, perfluorocarbon liquid, I remove it with the same cannula I injected. And then I reserve this perfluorocarbon liquid. If I see that, the retina is going down, I re-inject. I go to the border, and then I re-aspirate just to try to dry the subretinal fluid as much as
possible. You aspirate from the same cannula, you injecting the PFO.
Absolutely.
How is that?
When you re-aspirate, you can re-inject.
Absolutely.
But
And you
how,
have you don't
how
need
is that?
another bottle to use it.
Yeah,
Okay.
yeah.
Okay.
How do you inject? How do you remove the fluid? Do you remove it with two hands? You mean?
No.
Or what?
One hand. You have my light. My light is in the left hand now. Okay.
Yeah.
This is a soft thing you are seeing now. But in the beginning, when I overcome with the air, I overpass the giant retinal break. I aspirate with my cannula of perfluorocarbon liquid. Okay.
With
And
the
I
syringe?
go
With the
down.
syringe, you mean?
Yeah. My nurse is aspirating. I say
Ah,
aspirate, and I see it, and I say, okay, there is no fluid coming down, no excessive fluid coming down.
yeah.
Then I change. I grasp my soft tea cannula, and then I remove all perfluorocarbon liquid.
20% SF6, whatever the site of break, whatever the size and the
Oh,
site of break,
absolutely.
whatever.
3 and 6. No, if you have only in my life 3 cases, 3 and 60 degrees giant retinal break is your silicone oil. But for the remaining, I use SF6.
Even if lower.
Yeah. This is normal. Giant retinal breaks normally they stay in
Temporal.
200, 220, 240 degrees. With 20% SF6, I think is enough.
Okay.
Perfect.
This is the
You have the first 2 points here in our episode. Sandwich technique, and you can reuse the PFO after
Yes.
absorbing the PFO. This is
But
the
let me
first
tell you,
2
there is another important issue here. I explained to you before. You won't have any bubble of perfluorocarbon liquid. You go under air. You won't have, this dispersion of bubbles due to the water striking the surface of the perfluorocarbon liquid. This is very important. And you won't have the risk to have a perfluorocarbon liquid bubble under the fovea. You will decrease the risk of this.
It's another point.
Perfect.
Okay, you can continue.
Did you understand this?
Yes.
Yes.
Okay, perfect.
It's a nice trick, and the slushing and the PFC bubbles getting under the retina is a problem actually.
It's a problem because look at the problem. You have a giant retinal break, and you
there
are
is a
trying
break,
to see. You're seeing the break, but you don't see the borders of the break. If you are under perfluorocarbon liquid and fluid, and for any reason you decrease the pressure in the eye, then the infusion cannula begins to infuse, and then you create these bubbles. These bubbles, where they go? To the meniscus of the perfluorocarbon liquid. And where are the meniscus? In the borders of the break. And then you have these bubbles that enter in the subretinal space. If you have air in the anterior part of the retina, the borders are attached. Then you have no space for these bubbles.
And there is no stream going into the.
And there is no stream, okay, because there is no fluid entering, hitting the perfluorocarbon liquid bubble.
There is a request for Dr. Muhammad to translate these two tricks for the Arabic-speaking people.
Before translating, I ask you, Dr. Mateo, even we have a 360-degree break, joint break, may you use direct BFC silicone exchange, or you will never use this technique? You will
That's
always.
great. Let me tell you the truth.
In his life.
Yeah, no. Only 3 times in my life, okay? Only 3 times. But, anyway, I understand your question because many surgeons, very impressive surgeons, they use direct, perfluorocarbon liquid silicone oil. David Wong, many years ago, he described why doing this maneuver, you will decrease, the fluid going down. And the reason is that when you have the perfluorocarbon liquid here, and you enter with silicone oil, and the silicone oil contacts the perfluorocarbon liquid, they form a common interface, and the subretinal fluid tend to be maintained in the upper part. Then
in the donut part.
Yes, they don't go down. Yes. But at the end you need a second operation, and I don't like it. I'm sorry for that. I prefer only one operation. Then I don't do it.
Let's summarize the points of giant retinal tear in Arabic as a request of.
Sure.
التكنيك اللي الدكتور ماتيو بيتكلم عليه اللي اسمه ساندويتش تكنيك. الساندويتش تكنيك انك انت تعمل فلاتنج للجوينت ريتنال تير باستخدام البي اف او اندر اير. يعني انت بعد ما بتخلص زي ما بنقول از ماتش از كور فيتريكتومي يو كان، بتقوم جاي حاطط البي اف او اللي تقلب على اير لغايه ما تعمل دراينس للبريك از ماتش از يو كان. وبعد كده تقوم جاي حاطط بي اف او وتفلات البوستيريو بول او لغايه ما توصل للبريك، وبعد كده تكمل بقى شغلك كله بالاير. صح يا احمد كده مظبوط؟ وبعد كده بيقوم جاي هو معظم شغله بيستخدم اس اف 6 وما بيستخدمش سيليكون خالص. والبوينت الثانيه اللي هو احنا خرجنا بيها ان حته ان الريوز اوف بي اف او ديت ريوز اوف بي
هي كمان الساندويتش تكنيك دوت مفيد في ان هو لما يبقى في ستريم بتاع الفلويد جوه البي اف سي، ده اللي بيفتت البي اف سي بيخليه يتحرك ثرو البريك تحت الريتنا، وده كان بي افويدد بقى بالساندويتش تكنيك.
And this is the question, Dr. Matteo, and you are answering it also that you will not stop air infusion when you put the PFO.
No,
keeping
no,
care on.
no.
But he's asking about that the PFC sometimes evaporates and condenses on the posterior capsule of the of the lens in phakic eyes. What do you do?
Phakic or aphakic?
Phakic.
No, in phakic eyes you don't have any problem. The big problem, let me tell you, in high myopes mainly, when you are infusing air in the eye, you're at the end because you did your vitrectomy, you're attaching the retina, and only the laser, you need to perform at the end. Then be careful with infusion cannula. The infusion cannula has to be looking to the center of the eye. If you put the cannula be like this and is infusing toward the posterior surface of the lens, you will have opacification. Then put the infusion cannula down, and I don't have any problem with this.
We mean the condensation of
I know.
PFC evaporating.
First, you haven't removed the anterior hyaloid. This is, in a phakic eye, it's so difficult. It's not that easy. You have
yes, of course.
You have anterior vitreous there. I don't see this problem,
Okay, Dr. Matteo, you can go through.
Okay, let's go. Okay. More complex than this. This was the easy case. This is this is the easy case. Okay, let's go to the second case. This is much more the high myope problem. And in these patients, they have this posterior, as you can see here, you start your vitrectomy and then you go to a periphery. But look at this. To remove the vitreous in this case is so difficult. Why? Because look at the retina, it's so mobile, it's so thin, and the vitreous is so attached. And there are many places attached in very posterior parts of the retina. Look at this. We are aspirating, trying to avoid the retina come to me, and then you don't see the breaks. I know where are the breaks, but you don't. Okay, then I'm aspirating up a little bit, trying to put the vitreous anterior. But be careful because any place there is pigment, you can have a strong adhesion. Look at this. We arrive there and we continue up and up and up and up. But remember, in high myopes, you have schitic. Look at this. Look at the traction here in the posterior near the break. Okay, then I don't use them. I'm sorry for that. I use dyes.
Stop here, Dr. Matteo.
Sure.
Comment on that you are never use a triamcinolone, please.
I never use it.
You never use it?
I use it.
So how do you see the
Yeah.
And the posterior hyaloid?
I don't like it, my friend. I don't like it. I use triamcinolone in my infusion, and then I can distinguish between fluid and the vitreous, and then you don't have this white powder floating, and then this is the vitreous. Then I don't like it because when I use it, then I have to remove the posterior hyaloid with forceps or the ILM. Then these granules of triamcinolone becomes sticky to my forceps, and I have to clean them anytime. Then I don't like it. I know many surgeons they do it, but I don't like it. But you can use it.
If you need to
how do you ensure that the posterior hyaloid is removed?
No, let me continue. You will see it now. You will see it. Okay, then I stain, as you will see here now. Then I stain. Okay, I put perfluorocarbon liquid there, and look at this. This is, and you have to learn how to distinguish this. The posterior hyaloid that is there is not detached. When I started my vitrectomy, you see the vitreous there, and it seemed that the posterior hyaloid was detached. It's not detached. In these kind of myopes, almost always the posterior hyaloid remains attached to the retina. Look at this. This is not the ILM. This is the posterior hyaloid. How to distinguish between them?
This view from the contact lens, Dr. Mateo, right?
Absolutely. This is macular window lens. This is a lens for the macular area. This is a higher magnification. These are impressive stereopsis. I think it's not comparable with other kind of non-contact systems. I cannot compare. This is amazing. You are seeing what you want to see, and my experience, my stereopsis is so great that I
What kind
cannot
of lens
change
do
this.
you use?
This is macular window. The name is macular window from ABI. This is Advanced Visual Instruments.
This is from Dr. Mateo?
No. It's ABI. ABI Greenblatt. ABI Greenblatt produced this lens. But there are other lenses in the market. But they are contact lenses.
Because sometimes the lenses sometimes are so magnifying that you can see only the fovea and the parafoveal area.
Yeah.
And others get from the arcade to the arcade.
Yeah. When
Which
more,
one do you use?
by experience, when more field you have, less stereopsis you have.
Okay.
This is my experience. Then this look at the now the visual field I have. This is not too large, but I can see my forceps touching the retina. This is the only thing I want to see. Then I go there, I move the eye, and I have more field, and then I remove it with a perfect. Let me continue. You will see the ILM. Look at this. Again, this is so elastic. You see how this is. Look at the arcades. You see this is very. Now I stain again under perfluorocarbon liquid. This is the ILM. Look at the quality of the image. I don't want to see now the arcades. I want to see my ILM. I don't want to, touch the retina. I want to see my perfect ILM and to see it perfect with a perfect stereopsis. So important in high myopes, because look at this. This is the, posterior hyaloid again. Look at this staining.
So you remove the posterior hyaloid from the posterior pole.
And then complete.
And you don't complete the periphery. You remove the ILM, then you go to the periphery.
Yes. Then I go there. I remove as much as peripheral vitreous I can. Then I go down. I remove the schitic posterior hyaloid. I remove, in this case, the ILM, and then I continue to remove this. Because if you do it in the beginning, in my opinion, you will see how the attachment is. Look at the retina, how it's coming to you. Then one trick is, when you see that all the retina is coming to you, try to not to pull the retina. Pull the posterior hyaloid. I mean, one forceps, another forceps, and you tear. Yeah,
you do it in the ROP. Yeah.
The posterior hyaloid. Don't pull the posterior hyaloid because you are going to enlarge retinal breaks.
So you're creating the window, Dr. Mateo. You create the window of the posterior hyaloid from over the macula, and then remove the ILM, and then completed the posterior hyaloid.
Yes. Yes, but I go wherever I feel safe. Wherever I feel safe. This is for me an important advice.
This bubble of PFO, you needed to enlarge it as much as you remove the
I will do it, of course. I will do it.
But a nice trick that I want to confirm, you just take the lip or the edge of the hyaloid, and if it is too attached, you grasp it with two forceps and you shear it.
Yes.
You shear it sideways.
Yes.
Mariam?
Yes. Because if you pull more, you're going to break it.
Okay.
Okay. Oh, excuse me. I changed the slide. Let me
Very
try
nice
to
trick.
go again.
Very nice trick.
Let me. This is the posterior
This is the
highlight.
posterior hyaloid,
The
and then the
ILM.
ILM, and then the
Look at
mid-retinal
this
posterior
now.
hyaloid.
Look at this now. Then I
Yeah.
shear, as you can see, the posterior highlight. I don't pull more. If I pull more, there is one break posterior to this in the arcade. I'm going to enlarge the posterior break. This is so thin, the retina. And then I go up, and then I begin. Look at the mobile retina. You know, this is a crazy thing. This is very difficult to trim. Then I remove this, and I try to find everywhere. And then in this case, the break was there. But again, when you see these areas of hypigmentation, especially around the arcades, think that you may have breaks there. Be careful with this.
And you laser it?
Always. Excuse me?
You laser it?
You laser.
Absolutely. Absolutely. Any doubt, I laser. Yes. Absolutely.
But let's raise some questions here, Dr. Matteo.
Sure.
When you remove the posterior hyaloid, how can you judge that there is a break here, or just you laser it? When you find this pigmentation, you laser it, or you need to be confirmed that there is a hole here.
No. I try to find the holes, okay? But
How can you find it?
No. I go there and with the contact lens with high magnification, you can see it. You can see the breaks. Remember, I'm going to show you this. In these patients with these arcades, all of this pigment is very typical. You have breaks. Some of them are partial breaks, not only inner retinal breaks, but in some cases you have, these, full thickness breaks. And because of the posterior hyaloid is attached to the vessels that have been written before, be careful in the arcades. The arcades is always, I'm going to show another case, but in the arcades you have a big problem. Then I laser around the arcades, yeah. I tried to find the breaks, but I found it in that case. I found the break. Yeah, I found some breaks.
Do we have a macular hole in this case, Dr. Matteo?
No.
So you.
And then the question.
But you always.
Why peel ILM? The good question. Again, I come again. This is a retinal detachment. You remember that? Then, when the retinal detachment happens, the retinal elasticity decreases very, very, very fast. Believe me, that has been studied many years ago. Then remember that this case has a huge posterior staphyloma, and you want the retina to go down to the posterior staphyloma. Then I'm relaxing, the retina, trying to make this more simple, the retina to be attached.
There was
in the
a
area
paper
of the staphyloma.
published years ago about the stiffness of the ILM, and you have to remove it because the ILM is the shortened layer.
So the idea here is not in a myopic hole only. It's in high myopic cases. You need to peel the ILM to relax the retina.
In all cases like this, with posterior staphyloma and retinal detachment, even you don't have posterior macro hole, I always remove the ILM as large as possible.
In the same step as you're showing us here. Put a trypan blue or dual stain, then PFO, and then search for the posterior hyaloid. After creating the posterior hyaloid detachment, removing the ILM, you don't mention that you're removing in a flap manner or completing the remove the ILM to fear from foveal floor.
No. I never. There are some Egyptian papers that say that you don't care about crossing the fovea. My advice: never cross the fovea.
Never cross the fovea. So
go always in, never out.
Never out.
Never.
It's a critical step.
And you create a flap?
In this case, no. I trim it. It's not seen there a blue tag, but normally I leave some ILM.
You can tell it us like this: never, always in, never out.
Yeah, always in, always go in, never pull out because you can break the retina. Yes.
Okay. So it's a critical or a standard step in cases like this.
Yeah.
So when
I
you
think
complete
so.
this case,
Excuse
retinal
me?
detachment, high myopic cases, tell us about the tamponade.
In this case, for example, in this
Yes.
case, I use
Please don't say yes.
in this case, I use silicone oil. In this case,
Yes.
No, why?
Extreme.
yes. Let me tell you, because
Okay.
this is the only one eye. This is the only one eye. The other eye has
That's the only
poorer
reason?
vision than this one.
That's the only reason for that?
This is one reason for that. Yeah.
Yeah. So you use the tamponade in these cases. Usually it's gas.
In the majority of these kind of eyes, with this posterior staphyloma, with breaks that you have to look for them. Some of them are very small. In many of these cases, I have to compensate. I use silicone oil.
Okay.
Yes.
Okay.
Yes.
Dr. Mateo.
For me, it's
Dr.
totally
Mateo,
different. For me, this is totally different to a giant retinal break.
Yeah.
For me, giant retinal break. Let me make a joke, right? A joke. This is a simple case. This is complex case. These are for me. These are the more complex cases.
More difficult.
Dr. Mateo, you can answer some questions here.
Sure.
Dr. Khaled, what was the first stain, trypan blue or dual membrane?
No,
You
no,
are
I use
European.
good question. No. This was a brilliant blue, not triple blue in this case.
It's your usual stain, a brilliant blue. In
Let me tell you.
Yeah.
Any case that you can have stain under the retina, I use brilliant blue. In high myops, I tried to use brilliant blue. But in PVR cases where the staining of the membranes is not as good, in PVR cases, doing a special maneuvers, I use dual blue, triple blue, and brilliant blue together. Yes.
So I was meaning to
good
ask
point.
about this staining bit. So you stain under fluid, right?
No.
Under
I stain
air.
in the beginning. No. In the beginning, I stain. In the beginning, I stain under. Let me show you one thing that perhaps you missed.
Because I
Look at this. Look at this. Look at this.
Yeah.
Look at this. Posterior hyaloid. I stain. Okay. Okay. Look at this. This is. Oh, it's not seen in the video. I'm so sorry. Look at this. Look at this. I'm removing the posterior hyaloid now. Look at this now.
Under PFC,
Okay.
right?
This is PFCL.
Yeah.
The staining. Look at this. Look at this.
I've done
Then
it.
the staining takes seconds, a fraction of seconds, to stain the ILM. Then you stain in the interface between fluorocarbon liquid and the retina, and always there is a layer of water there.
Yes.
And then you go there with your high magnification lens, with a perfect, stereopsis, and you go in between and you stain. Then, the perfluorocarbon liquid pushes the staining towards the superior surface of the bubble. You understand this, right? But,
Yes.
the staining is seconds.
It's seconds, yes.
And then you remove.
But you don't stain under air, right?
No, in this case, no. In some cases I do it, but I don't use it now.
Because I've tried it in one time in these cases, and stain entered under the retina. It was a macular hole, and it got under the retina. Thank God
Sure.
I removed it, but
yeah. When we were together before we started, I explained to you how to avoid it.
Yes.
Dr. Mateo,
you care to repeat
about
that?
The laser
Can you repeat that? The trick where you can avoid the slippage under the retina?
Yes.
What you just told me.
If you have detached retina in a macro hole, for example, okay?
Yes.
Okay, here?
Yes.
Retinal detachment, macro hole. Then if you send the dye, the dye will enter its retinal space. This is so easy, it's easy to understand. Then there are two different kind of retinal detachments. One in a macular hole. One is the detachment that you have a macular hole, and detachment goes to the periphery. This is very simple. You do your vitrectomy, and then you put perfluorocarbon liquid, and then you make a small retinotomy at 12, for example, and then you remove the fluid, the retina is attached, and then you stain under perfluorocarbon liquid. But again, it's the same problem. The hold is attached. Then you don't have a space for the dye to go under the retina. You will stain, inside the hole because, sometimes you stain inside the hole, but you don't stain, all of the macular area. The second situation, more complex, is imagine this case, you have a detachment in the area of the staphyloma, right? Okay, and you have a macular hole. The problem, as you mentioned before, Mohammed, is that if you do, air exchange, okay? You mentioned this, right? You mentioned this? Okay, you do air exchange. Your visualization is becoming very poor. And then you go down and down and down, and you begin to aspirate through the hole, but your visualization is very poor. And the second thing is that you are not attaching the retina, because always there is fluid under the retina. And then you inject the dye, and all the dye goes down under the retina.
What will do in this situation?
Okay, then, and this is the most important trick I'm going to leave today. Imagine you have the cap, and then you have the retina detached. Then under fluid, you inject perfluorocarbon liquid over the disc, okay? And then you are going to create a bubble of perfluorocarbon liquid over the staphyloma. And the retina will remain how? Detached, because you close the break, right?
Fluid inside the staphyloma, yes.
You close the break. The fluid cannot go anywhere, okay?
Yes.
Then, under a contact lens, perfect view, perfect stereopsis, you grab 41 gauge cannula, and under, the macular hole, the macular hole like this, you enter in the hole and you begin to aspirate. And then you will see how the retina makes like this. And suddenly, in 1 minute, it will be attached.
And how much is your vacuum?
As high as you want, no problem, because 41 gauge is so thin, and your visualization is so great, and you are under fluid, you are not under air, and you see everything, and then everything, and you begin, and you know how you notice this? When you put the perfluorocarbon liquid, you won't see the choroidal vessels, because when the retina is detached, is translucent, it's not transparent, and then you don't see the choroidal vessels as you can see it now, okay? Then when you begin to aspirate, perfluorocarbon liquid begins to weigh down the retina, and you will see how you begin to see the transparency of the retina. You are going to see how the retina attaches.
You aspirate 41 gauge in active aspirate, connecting it to the machine, yeah?
Yeah. Connected to the machine. To a foot pedal.
Aspiration.
Dr. Mateo, this trick is used to make sure that we aspirated all the fluid in the staphyloma, right?
No, you never aspirate all the fluid. Be careful with this. You never ever aspirate all the fluid, because part of the fluid will remain in the lateral part of the staphyloma, but you will attach the center, because the bubble will attach the center. And then under perfluorocarbon liquid, around the hole, you begin to stain. And then you will have the staining.
Do you have a video demonstrating this technique with Mateo?
Enter. Okay. Okay. Then I will try to find it, okay? But go to YouTube, as I told you, go to YouTube. There is one video, this is macular buckling, Carlos Mateo. It's a long video explaining all about macular buckling. And in part of, I think it's minute 8 or something like that, I, explain the two kinds of retinal detachment, the broad one and only the macular one. And you will see how I do it. This is very simple.
But Dr. Mateo, you don't think if we just do IL revealing and we close the hole, this fluid will be away from the pump only? This is enough and we need to I read it.
I lost
If
you. I lost part of the question. I'm sorry.
كمان مرة يا طارق.
يا طارق عشان
in these high myopic patients with posterior papilloma, if we didn't do this technique and just do ILM peeling with inverted flap, this will be enough to allow
Absolutely. 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 Absolutely.
So
Then
so the
imagine the situation. Okay, imagine the situation. You are under perfluorocarbon liquid. Okay, then the retina becomes more transparent. You have some fluid in the periphery of the staphyloma, right? Then you begin your iron peeling. Okay, but under perfluorocarbon liquid, when you peel, the ILM stays there. It doesn't make like this. Okay,
Yes.
then you put it over the hole. That's done. And that's done.
And you in these type of cases you aim for closing the hole or just flattening it over the.
I always put the ILM flap over the hole. I don't put it inside the hole.
Yes.
If the macro hole is
and
too
it closes. Does it close?
Yeah, many cases it closes. Yeah. Then we can enter here in the discussion about macro buckles or ILM flap. Let's continue a little bit more. We will discuss this. It's a long discussion.
Let's go for next case, Dr. Matteo.
Excuse me?
Let's go for next case.
Okay. Let's go to another case. Look at this. More complex, this one. More complex because in this patient has cataract, artisan lens,
yes,
retinal detachment, and I don't see the retinal break. Okay. I put the buckle, as you can see here, with these muscles. I always put my buckle in. This is only 12 minutes, Okay, then I do lensectomy.
For you, maybe.
No. It's a question of training. No, believe me. No, so easy. So easy. Believe me on that. Okay, then I do lensectomies. Wonderful technique. You have to learn how to do it. I know you know how to do it. But look at the pupil. It's wonderful. I now cleaning the anterior capsule. Look at this. Look at the retina. How mobile it is. You don't see any break. The retina is very mobile. The vitreous is so difficult to remove. Then look at this. Now I'm going down. I didn't see. It seems a macro hole, but there was not a macro hole. And look at the posterior hilot there. It's so adherent. Then in this, excuse me. Let's go to the next. Okay. In this case, I had to forceps and scissors to cut the attachments of the retina. Don't pull. Just pull. If you see that all the retina is coming to you, just grab your scissors by manual surgery, like another diabetic patients, and just continue to do this. Look at this.
So you're saying a chandelier is essential in this?
Yes, absolutely. Look at the posterior hilot in this case. Look at the posterior hilot. It's so dense. Then I'm going up and up, but I have to use my both hands to detach from the strong additions of the posterior hilot. Then it's not as simple as let's put some triamcinolone there, and then with my Vitrectomy tip, let's go up and up and up. No, because you can make many breaks in these patients.
If I need to use a stain to more visualizing this posterior hilot, may I use a trypan blue or brilliant blue? Or
let me continue. Now it could be a mess because I don't know what is the break. If you inject it now, that I'm going to do it now, you can have a mess inside the eye. Then the first thing I want to know in this case, you know what is? Where is the break? Is a posterior break or is an anterior break? In this kind of cases, it's by far more common to have a posterior break. In a normal myope patient, anterior breaks, giant breaks, multiple breaks, anteroposterior breaks is very often seen. But in these kind of cases, with these atrophies, be careful. This is so often that you have posterior breaks. Then I'm going to do one thing. I'm going to perform a fluid exchange. If I see that, the retinal detachment almost disappears, it means that you have a posterior break. Then, if you see that, all the subretinal fluid accumulates in the posterior pole, you have an anterior break. Then in this case was a posterior break. Look at this.
What's the explanation for this?
Yes, because now we are putting air, right? Do you understand this? Okay, then I'm aspirating in the optic disc, right? Okay, then if you see that all the subretinal fluid and the retina begins not to attach, but begins to flatten, it means that you haven't closed the break. Okay? If there is an anterior break and you do this, you are going to accumulate all of the retinal detachment in the posterior pole, and you will have a bullous retinal detachment in the posterior pole. Can you understand this?
I get it.
The anterior break becomes dry, and it
of course, and you close it. When you close it, the fluid cannot go anywhere. Goes
and it accumulates in the posterior pole.
Yes. And then if you aspirate in the posterior pole and you feel that the retina has become, more attached, more, less fluid, then you know that you have a posterior break. Let me show you, because it was not easy in this case. Then I'm going down, as you can see here. Look at the fluid. I have less and less and less fluid, and there the view is not good. But look at this, and I'm going down. Then I'm going to stain over the places where I think the break may be. This is brilliant blue, less toxic than trypan blue under the retina.
And you are not fair if it's goes through underneath the retina. So
no, it's going to go, but I want to see it. Where it's going to go. Okay? I put some drops there. Some drops over the places. Look at this now. Around the optic disc. You see now how
now
this
is under the retina, right?
It's under the retina. Then I'm aspirating there. You don't see the break, and the break is just around the optic disc. Then in this case, so difficult. Look at this. You have some dye under the retina here, and you can perform a peripheral retinotomy, and that's done, and you don't have any problem.
Around the disc, what would you do?
Okay, let me show you. My friends, Italian friends, mainly Stanislao, he described how to put the ILM inside these breaks in the posterior pole, and I did it in this case. This is a part of this. It's very difficult to record these cases because, these white areas are very difficult. Then I put, this, plaque in the, over the hole. But let me tell you the truth. I do laser in these white areas of atrophy, and it works. You don't see it, but it works. And then, I put this, patch of ILM, inside this hole. But, again, I did laser around the break. And this is,
So speaking about laser, do you do a 360 barrage?
No, not in this case. No. I did laser in the periphery. I did a buckle. Remember the buckle. I do laser around the break, the small break. I did to remove, the remaining fluid. Okay.
Yes.
What about the trapped fluid in the periphery, Dr. Mateo?
What?
The trapped fluid.
No. At 12, I do a small retinotomy, and then I remove from them. Yeah.
But I didn't get the point how you reach the site of posterior break beside the disc. I didn't get the point how we can reach in this posterior atrophy, and there is no good reflex with RBE to get it this.
But you have the dye. Then imagine first you have magnification lens and you see perfect under fluid.
I think we can get it a point in myopic macular surgeries. My contact lens is a clue. Yes.
No. I use contact lens for always. I have to treat the macular area. My videos.
Not only in
what you're basically saying, it's like a perfect system that is interconnected. You have the lens, you have buckle,
everything is connected in life. Of course.
If you
Of
want to do
course.
this style, you should do it all.
Yeah, no. Remember, at the end, when you try to compare results with the different surgeons, you have to take into account not only the experience that is different in everybody, but at the end, it's different in the settings, in the things you use, and I think this make some differences. But in my settings, this is the best way to manage these problems.
Okay.
Then again, magnification. You see the dye under the retina.
Yeah.
And then I go with my aspiration, my soft T cannula. When I suspect you can have a break, around the vessels mainly, always is around the disc and around the arcades. Remember this. These are the places around the disc, even in the nasal area, and in the arcades. This is the most common, and of course macro holes. But these are the three places where you have to try to find them. Okay?
Okay, good.
Then at the end, I
Then
went
you
there.
move the
At the
lens,
end-
and you didn't
No.
implant,
Dr.
right?
Dr. Matteo.
No, I removed them. I removed the.
Keep the last. Keep this photos. Keep this photo posted. The last photo.
Last
The
photo
post
is.
op. The post op. The post op.
This is the photo. This is only air.
This is the side of. This is the side of peripheral break. This is the side of peripheral break. You do it, yes, to drain the.
No. This black
right?
one. No. It's not seen. It's in
No,
it's at 12.
it's
It's not
30.
seen. It's not seen. I'm sorry. It's not seen. But
It's
here
not
you
seen.
see the buckle. Okay, you see the buckle. This
The buckle is
area in the temporal side. This black area in the temporal side, in the mid periphery. This is a previous, RP lesion. This is perhaps was congenital. And you see in the upper part, you see in the mid periphery, you see about laser, because I found that something strange there, and then I laser. Okay.
Yes.
But you don't see the laser. This is only gas. This is not silicone oil. This is only gas, because I was sure that the break was there and not in other places.
And not in other places. How?
Well, because I try to find. I have to find every around the arcades.
You do internal search, meticulous internal search.
Yes.
Yes. And you don't implant an IOL.
No, this is a high myop, my friend. This is a high myop.
Doesn't matter.
This is if you calculate, perhaps this patient has now -2 or something like this.
Yes.
Lensectomy for these patients is an amazing thing.
As I remember, you prefer to do barziplanal lensectomy. You prefer to do barziplanal lensectomy.
Absolutely. I prefer I would prefer always.
Why is that?
We have a couple of questions about
there is, but this is another, in a high myop like this. Imagine that has not been with an artisan lens, okay? In a high myop like this, if you remove the lens, doing a lensectomy, you convert a high myop to an metropic eye.
Yes.
Now, yes, in your visualization, and then the trick is, I'm very used to do it. I must confess that I have been 30 years doing lensectomies, but the trick
is it's easy, but what is the rationale for it? Why don't you do a normal phaco?
I always say, try never to open the anterior chamber before your vitreoretinal surgery.
Because
in a complex case. An epiretinal membrane, that's great. In a macro hole, in an metropic eye, that's great. In a PVR, in a high myop, even in a very complex diabetic patient, believe me, if you don't have anything in the anterior chamber, your visualization will be better. I think nobody in the world agrees with me. I understand it. I understand.
You're enough.
No, I understand because, many vitreoretinal surgeons now are, anterior segment surgeons, and they love it. But, I don't love it because I use, phaco emulsification. I don't do too many. But if you compare the visualization of a lensectomy with a phacoemulsification and a lens insertion, because you do the phaco and you put the lens, believe me, totally crazy difference. Try it once. Or I can show you a lot of videos showing this. In a high myop, you remove this, and at the end you will decide what to do with if it's a lens or not. Try it once. But the key is don't break the anterior capsule. This is the key. Then you have to maintain the anterior capsule there. You polish, as I showed you before. You polish,
and you leave it there.
Huh?
You don't remove it all.
No, at the end you decide.
Why?
At the end you decide. No, at the end I decided. Some cases I leave it. Let me tell you why. If I use gas, I always do a capsulorhexis from the pars plana.
Yes.
Because when you put gas in the eye and the patient does not do a perfect face down, then you can push the iris towards the cornea.
Yes, I know this.
Then you can have,
the IOP will get so high.
Yes, my friend. Then if you leave the anterior capsule, you won't have any problem.
But after a time, the anterior capsule will be ossified and make a visualization.
No, you're wrong. Absolutely right. I can demonstrate this. Absolutely. If you polish. If you don't polish, it will be opacified in 1 month. If you polish, look at this. Look at this. Look at this. Look at this. Look at now. Okay? And now, look at this. This is the anterior capsule. These white granules there, these are the capsule. And then I'm polishing this. I'm polishing very low aspiration.
In this case, you're keeping the anterior capsule and didn't remove it in all cases that you need to do a clear lens or lensectomy. So,
no, I do lensectomy. My indication for lensectomy is these high myops in PBR cases, severe PBR cases where I have
the anterior capsule.
No, the anterior capsule. Normally, I leave the anterior capsule. In some cases, I do a capsulorhexis, but in some cases, I leave the anterior capsule there.
Oh,
yes.
This is a good point. So when I decided to do
only one at the same time. Only one. Oh. Tell me.
When I decided to do a lensectomy, I usually remove the whole capsule.
You don't need to do it. Don't do it. If you leave gas, you have the problem that the gas can push the iris towards the cornea. The second thing is that if you do silicone oil, I do a central capsulotomy, but I leave the anterior capsule there just to avoid that, just to have a barrier between.
And you don't do an inferior iridotomy?
Yes, I do it.
You do it.
Yeah.
With the anterior capsule in place?
Yeah. In the majority of cases, I do it.
It doesn't interfere with this.
No problem.
Okay.
But I think this Japanese iridectomy, Dr. Matteo, will be all through the anterior capsule and through the iris.
Yeah, you can do it. Yeah, of course. You can do it the same. Absolutely. Yeah, you can go behind the anterior capsule, and then you eat the anterior capsule and the iris. This is no problem. Yes.
Okay.
Okay.
Go to the next, Dr. Matteo.
Let's go to the next video.
Oh. Okay.
Okay, let me a case. Let me a case that happened to me. This is a patient I knew for 30 years. I operated here for a giant retinal break in the other eye, and has this. And at the end, this patient developed this. A tractional, a macro hole or disguises and detachment. And then again, the same problem, the vitreous and all of this stuff. I do, in this case, dual blue staining. There was not a macro hole. Look at this. This is the posterior hyaloid. I have some staining. This is the posterior. I don't use, tamsinolone. If you use it, that's great. Then I went there and I removed the posterior hyaloid, as you can see here. And I saw this aspect, but there was no macro hole at that time. And then I did my Allen peeling, always going in, no going out. Remember that. There was not a macro hole, then always around it. But I left this, this is, 6 years ago or something like this, and then I went there. Look at this. They did make fluid exchange 20%. It was perfect. Wonderful surgery. Look at this. But this is 12 days later. What was the mistake, my friends? The mistake was...
This is a choroidal detachment, right?
Huh? It was?
This was a choroidal detachment?
No. Well, there was a choroidal detachment because hypotony related to the retinal detachment. Okay? Then the problem was that when I removed the posterior highlight, I left in the pigmented area a traction there. Look at this here. Then if you try to remove it, you will break more. Then for me the advice to you is where there is pigment, be careful. This was the pigmented area. Where there is pigment, be careful.
Do laser. When there is pigment, do laser and don't
and be sure that you haven't broken the retina when you remove the eye.
And if you're not sure, you do laser, right?
Yeah.
Let me raise a question, Dr. Matteo. If you have faced a problem like this one in a recurrent RD in a short days, you also put another SF6 or you put a silicone again?
No, in this case, I put silicone oil in this case.
Why?
In this case, why? Because the other eye was operated many years ago. Visual acuity was 20/400. This was the best eye of the patient, and after being for 2.5 weeks face down, then the retinal detachment. Remember the choroidals. Remember the hypotony, high myop.
Yes.
Then I decided to be safe.
So what is your indication? What are your indications for silicone oil injections?
Only one eyes.
Yes.
Hypotony. Many, more than 2 surgical procedures. Kids. These are for me. But if I look not in myopes, but what is my most important indication of silicone oil? Is PVR. PVR and hypotony.
But in high myopes, whenever I see this kind of high myop, I always put silicone.
No, that's great. That's great. No, this is no discussion about it. Yeah,
I want to put gas.
Yeah.
But I'm always afraid of the first recurrence. But I'm
you're afraid.
Also worried when I'm removing the silicone. I'm also worried about the.
Of course.
Break.
You have to be worried about 2 things: redetachment and hypotony in high myopes.
Yes.
Okay, there are 2 problems in high myopes.
That's why I fill it with air or gas after removing of.
Yes, I do the same, my friend. I do absolutely the same. I always put gas or air just to see if the retinal reattachment reappears. Then you can control it. Okay, but let me tell you one thing. The question for me is why not you, me, and everybody in these high myopes we use sometimes or almost always, whatever you want to say, silicone oil. Why? Because we are not sure.
Because I'm afraid.
No, you're afraid. Why? Why are you afraid?
Because you are not sure. Because
there is more breaks.
Yeah.
Then it's important to try to look your vessels around the optic disc. Try to rule out any break to see the periphery and all of this stuff. But anyway, at the end, you are not satisfied with this, and then you say, okay, I will be very happy if I put gas. And the problem is that if the retina redetaches, as in this case, you will have hypotony. And hypotony and high myopia is not good.
Yes, choroidals will do PVR in most of the cases.
Yeah, but not only PVR, but choroidals. Choroidals for me is almost is terrible for me in high myopes.
Because
but,
of the
PVR is another problem.
Because of the PVR that is caused after the choroidals are gone. Or what?
No. Why, the PVR sometimes the choroidals ended with the vision. The patient goes to the hypotony, choroidals, and vision becomes half movements or less, and some of them redetach and they have PVR. Then for this, that's perfect advice to use silicone oil for this case. But at the end, the second surgery, you have to pray.
Yeah.
Always
I always pray before. So do you close the sclerotomies with a suture for the
When I use silicone oils, always I close my sutures. When I use silicone oil, always I suture. Always.
You remember Tarek? You remember Tarek?
When I came back, Dr. Mateo from Barcelona, I told them 100% of siliconized cases should be sutured. And actually, when we did that, we didn't find any silicone under the conjunctiva anymore.
Any silicone, Dr. Mateo.
Yeah,
I learned it from Tarek when he came back from IMO, and he told me that Dr. Mateo is suturing 100%. I am doing this.
Yes. Well,
Okay,
let me tell you.
We can go for the next case, Dr. Mateo.
Sure. Okay. Then I'm going to talk about now, macular, traction maculopathy, and let me show you the first case. All cases are, cases, problem cases. Okay. This is the first problem. This patient was sent to me by a very good friend of mine, and he operated this patient, and he did a perfect vitrectomy, and then he told me, Carlos, you have to put a buckle in this case because I did perfect surgery, and the patient has the same schisis. My question to you is, what's your answer to this case? What could you do in this case?
For this case, what is the visual acuity?
Visual acuity is 2400. No, it's 2100. 2 months later.
I don't think I would enter.
For me, it's about the visual demand of the patient. And
Patient was demanding.
It's demanding?
Yeah, absolutely.
Okay, you will
This is
enter
excuse me. This is the best eye for the patient.
the best eye.
The ILM is there. The ILM is there.
You have to tell me. You have to tell me. I told you.
I think it's there.
No, you have to tell me this.
I would have if he's demanding and stuff like that. I would remove the ILM for Fovea sparing and if I can.
No, but this case, let me remind you, this case I've been operated by a perfect surgeon, very skilled surgeon, and then he's sending me this patient because he didn't understand why it remained the same. But I repeat again, perfect surgeon, not a
So if it's a perfect surgeon, he would
not a
have removed the
fellow.
ILM. Yes, okay. He would have removed there's a high possibility that he would have removed the ILM. So I think because of the staphyloma, the staphyloma increased and the foveus cases increased.
You are in the way. He's a perfect surgeon, but even perfect surgeons, they fail. Okay, look at this. The answer is, the ILM is there. And I told my friend, you left the ILM. He told me, Carlos, this is impossible. You know me. I'm a perfect surgeon. I said, I know you, but you left the ILM. Then, in the picture, you see the ILM has not been peeled away. Look at this. What happens when you peel away the ILM? This is a macro hole I operated many years ago. And as you can see here, you see the pre-op. You see the first day post-op, the macro hole is closed. This is 4 months or 1 month later. And look at this 6 months later. And we find these, Dunfels. This was described many years ago by the group of Alain Godric in France. And we call these CNDS with my friend and colleague Nicola Alcaves from Italy. We wrote a paper about how to find these Dunfels. This is the same as concentrical macular dark spots.
Yes.
When you peel the ILM, you always have, these Dunfels, these defects in the inner surface. Okay, but I went to my machine, to my OCT, and then you see. I don't know if you see my pointer. You see my pointer now?
Yeah.
Yes, we can.
Okay, perfect. Look at this. This may be, the Dunfels.
That's the
Oh,
pinch. I think that's the pinch that he tried to
He's
do.
trying to create island.
okay, let me give you the answer. Okay, look at this. Okay, I go there with my OCT and I'm going to cut where this is there. Look at this. I'm going now there. I'm going to up and down. Look at this. Go to this concentric market, and now results that this is here. This is not dolphins. These are not dolphins because you have to cut in the internal limiting membrane. These are not dolphins. Then it can be a mistake to think that this patient had been previously treated with the ILM removal. His surgeon, hair surgeon, was very sure that he removed the ILM. And then I told him, my friend, you haven't removed the ILM. Let's see. Look at this. What is this?
This is the ILM.
This is the ILM. But not only the ILM. Look at this. Look at this. This is partially posterior hyaloid either. He didn't remove the ILM. And this happened to me either many years ago. Then we have learned a lot about how to peel all of this. Look at the ILM. All the ILM was there. This is so rigid.
So what
so
did he
unstable.
peel? He peeled an epiretinal membrane, you mean?
Yeah, he peeled partly the posterior hyaloid. Partly, not all the posterior
So do you
hyaloid.
see the Domfil in all cases of
Let me
removed
try
ILM?
to find it. Let me try to find it. Excuse me. Next slide. Look at this. Look at this. And look at this. And look at this. Okay, look at this. These are dolphins. Okay, look at this. These are
So do you
dolphins.
see it in all cases with removed ILM and
All
high myopia?
cases, my friend.
All cases.
All
Okay.
cases. Well,
So that's
let me
a
tell
sign.
you the truth. Let me tell you. Look at this. Look at this. We go there and look at these are inner dimples. Okay, these are really the dolphins. These are real dolphins. Okay, then don't be confused when you don't know where are your machine cutting. Okay, then you put a question that this is perfect for me. Look at this. In all macular holes that you peel the ILM, you will find the dolphins. In emmetropic eyes, you will see them in one month after the surgery. For high myopes, it takes a little bit longer. But in epiretinal membranes, when you remove an emmetropic eye and you remove the membrane and the ILM, you will see dolphins only in about, let's say, 30 to 40%, 50%.
In what cases? In what cases?
In epiretinal membranes.
Yes.
Imagine, I don't know, you remove the ILM in epiretinal membrane, right?
Yes.
Okay.
I do.
Remove it.
I do. Yeah.
Yes. Then we remove it. Okay. Then in these cases, in many cases, you don't see the dolphins. You know why?
Yes. Why?
Because the aspect of the retina after the retinal membrane is thicker than normally, and you have edema. And this edema, this is a theory. This is our theory. This extracellular edema makes that you don't see the dolphins. These, fulfill the spaces between the.
But the edema will go away, right?
Huh?
It will go away.
No, it's not true. Many of the majority of patients with retinal edema, they stay in 400, 500 microns, and they stay forever. And it is not related to the visual acuity. Some of them has 20/20, some of them have 20/50. Then, the increased thickness of these patients, can be stay forever. Then not, only in a work we made at IMO, only 33% of the patients with an epiretinal membrane return to the normal, contour. Only 33%. The remaining, they had edema in the corner, in the retina.
That's for high myopes or
no,
any?
in high myopes, you don't have. Let me say this: you don't have epiretinal membranes. You have posterior hyaloids. And try to remember a case like this with an epiretinal membrane as you think when you are talking about an emmetropic eye. You won't find many. many
Yes.
cases of this.
Yes.
You're the expert.
Then be careful because in high myopes, yeah, tell me.
Dr. Matei, the clue here in MTM is to be sure that you can totally complete peeling the ILM. So if
Yeah.
you are not sure that your ILM is totally peeled, you will face this problem.
Yeah, restain.
Yes, and you stain under the PFC.
Well,
under
depending.
PFC or not?
I use in some cases I use it, in some cases don't. If I have PFCL, I stain under PFCL. If I don't have PFCL, then I restain.
I mean for good staining. You mean as you said, for good staining, you put also
it's perfect.
PFC.
It's better staining with a PFCL. But at the end, in some cases I don't use it, and it's very expensive. And to put it only to stain, it's too much for me.
Yeah.
Then
that the idea, the clue here is the contact lens, the magnification.
Believe me, it's an amazing thing.
We have a lot
let me tell you. Then when you go to meetings,
the disposable one, right? You use the disposable one.
No, mine is not disposable. You rest your eyes. But there are disposable ones that they are perfect. Perfect.
We have
and there are many. But the lens I use for me is the best one. This is the macro window. For me, is the best one. Okay, because I see what the patient is thinking. Normally.
Dr. Matteo, can you answer this question clearly? You try to peel the ILM without contact lens?
No. And there are plenty of impressive surgeons that they do it under wide field lenses, and you do it a perfect job. But I don't. If you make a break here, you're lost.
That's why I was asking. If you make a small break,
I can show you cases of mine.
I got so scared that I will remove the silicone. While removing the silicone, I get so scared from this small break that I can see with the OCT. It's so small that I did while removing the ILM, and it's so dangerous, right? It can redetach the retina, right?
I agree, my friend. I agree. If you make a break,
what do you do about it?
Yeah. If I make a break in the staphyloma, you're lost because the retina is stretched. You are increasing elasticity, removing
no solution for this.
No, I do laser.
You do this.
I do laser. The problem is not that. I could because it's not in the presentation, but I could show you a case very similar to this. It was more complex, but anyway, I removed the ILM, but in one place I touched the retina with a contact lens, and a small hemorrhage, and I went there and I saw the hemorrhage and I said, okay, this is nothing. 2 months later, this nothing was a break like this. Why? Because the retina is stretched. Then if you have the problem that you make a small, tiny hole, you can end with a really big hole.
So let's answer the question with Dr. Tamer, that the incidence of secondary macular holes with ILM in high myope and is less when you peel under the PFO or not?
Repeat again.
Is the question here, what's the incidence of the secondary macular hole with ILM in high myopes? And is this percentage?
That's very low. It's very low. I don't know. It's very low. This is a good question. In a macro hole without retinal detachment, we're talking about, okay? In a macro hole without retinal detachment, you peel the ILM, then you can have recurrence of the macro hole. It's very low. We publish a series of cases with more than 30 millimeters of axial length. And then we were able to close, using the inverted flap, to close all the cases published in Retina. So if you want to find it, it's published in Retina. But I had 2 cases that recurred. 2 cases. But if you compare to other series, Grazia Pertile and another series from the group of Poland, Bikaleska, they didn't have any. But let me tell you, I have more than this in other series. As I continue, I had other cases that recur. It's very low, but it may happen.
Low.
It's very low. It's very low.
In this series, Dr. Mattei, you did only removal of the ILM or enveloped flap?
No.
He
Excuse me
never
again?
removed the eye.
In
He
these
never
years
removed the eye.
you're telling us about, you did inverted.
No,
and
I do in high myopes, especially more than 30. I always invert the flap. Always.
Reverse the
I
flap.
always.
Okay.
I always do it. You know.
We can
always.
go to the next case, Dr. Matteo.
Okay, let's go. No, this is just to share the difference with the staining between the posterior hilot, again, elastic, very bad staining. As you can see here, staining is very irregular and it goes wherever it wants. But ILM is the most rigid part of the retina. It's 1,000 times stronger than the other retinal layers. Then, you know, it goes wherever you want to go. It's like the capsule, the anterior capsule. Then, you know, you have to distinguish between the posterior hilot and the ILM. If you doubt, re-stain again, okay?
Okay, it's a good idea.
Okay, let me show you this. This is a question for you. Look at this. This is a Portuguese female. This is you have here the left eye with a, you know, scar atrophy, visual acuity was 2400. And all my cases have drops, okay? Then, of course. Then she came with this 2032 vision and this aspect. My question to you is, when is the right moment to operate? Because, you know, this is 2032. You have a focal detachment, but, you know, this is 2032. And you know, what's your answer, my friends?
he has only myopic previous cases. There's no detachment.
No. Only this is a ascites only.
What is she complaining of?
She's complaining that she noticed that she is not seeing the same. The news information. Excuse me?
What
She has
is her
no
job?
mechanism.
What does she do? For a,
No.
for a
When
living?
she reads, he noticed that she cannot read. She noticed that in the center there is, you know, she loses some letters and it's more difficult. Then she went to an ophthalmologist in Portugal, and then they make the OCT, and then they bring me this and say, Dr.
I
Matteo,
wouldn't do surgery.
you
If
wouldn't
had
do surgery.
edema, I wouldn't inject either.
Actually,
Okay.
if she has no metapropotia, I will do nothing.
You will do nothing. Okay. Let me. This is a real case. This is, you know, as it was.
Yes.
Let me tell you, this is for the young people because this I have a traps. You know. Okay. This is you know. Let me tell you, and now, this is the same eye, the same day, the same machine.
You got
Everything is the same. This is a macro hole. This is not. This is the patient I operated with more risk in my life. Let me tell you, because you know. But this macro hole is not going to go better than now. Then this is going to increase in size, and you know the patient is going to lose vision.
This is why, sir, Dr. Matteo, this is why in Barcelona they were calling you Messi of the retina.
No, don't think that. No. I'm showing the only thing I want to express with this case is never lie on one cut.
Yes.
You know, I receive many patients that they bring me, you know, the OCT, one perfect OCT, because the doctors, you know, and I will say the same. Excuse me, I have to repeat the OCT. I want to see all the lines. I want to see if there are more things that I cannot see in only one cut. Can you understand this?
Once you find tiny hole, you will proceed to surgery, Doctor.
And then, yeah, of course. In this case, of course. But, you know, I can explain the patient. I explain the patient. I say, okay, look at this. This is not the same like this. You know, this is a macro hole, and this is not going to go down. This is not going to, you know, do spontaneously, going down, and this is not going to happen. And then at the end, we operate.
That's why we insist all the time that we get the just center of the foveal point. We always insist on this. Yes.
Let me ask you, Dr. Matteo, if you have these two pictures of two different patients, we will not operate in the patient on the left side. Okay.
Left eye with only foveal detachment, I repeat the OCT and I see there is no macro hole, I would say, my
You will
friend,
not be operated.
you are going to be operated, but not now. Just, understand that this will, more and more and more and more decrease in vision. Then you have to be aware of this. But the patient,
Okay.
Except in this case, but the patient has to understand that they are losing vision. They have to, interiorize that, this is a big problem.
So I want to ask you about a case about the same issue about the small breaks. Can you share, Muhammad, my screen? So this is a case.
Are you stop it? Are you stop it?
No. Keep it.
No. Keep it in the background. Keep it in the background.
Okay.
So
You
this
see video of the Ahmed, Dr. Mateo? You see the video of the Ahmed?
No. Let me.
Just
Yeah. Now I can see it. I can see it
okay.
now.
So this case was referred to me. He was she had 2 times retinal detachment and she had a trauma and a macular hole, and she detached and this was she did the first 2 vitrectomies outside, and I decided to enter to try to reattach the retina and do an inverted flap over this hole, and I did the I did the inverted flap, but I pinched a little bit temporal, as you said. I'm not sure if this is the ILM or this is an epiretinal membrane, because there is staining, as you can see. You can see this staining, right?
Is the ILM with cells? This is the with some retinal tissue, but I think this is the ILM. This is your ILM. I think
the inverted thing is the ILM. So I tried to take to enlarge the flap a little bit, and a pinch happened, and I pinched a little bit too hard in this area. Okay, and after in the post-operative period, at this area there was a small break, and the retina is attached and everything is okay, but there is a defect in this part corresponding to this small pinch. So what do you recommend? Should I remove the silicone or
yes?
Or should I leave?
I could do laser around. This is a small break, laser around. That's it. For me, the case how I could manage this again. Retinal detachment, right? Was a retinal detachment.
Yes.
For carbon liquid to the periphery. Okay. For carbon liquid to the periphery, then a small retinotomy up. Then you remove it, and then under before carbon liquid, I would put the flap. That's done. But I have these hemorrhages like you have. I can show you cases with breaks in the area of the staphyloma, because remember that the temporal retina is thinner.
You just said that small breaks, you cannot. There are no solutions for this, and it's a problem, and you will lose the retina, right?
No, laser. I would do laser. Around.
Laser. And I can remove the silicone.
I think so. I think so.
Okay, Dr. Mateo, can you proceed for your case, please?
Okay. Okay, then don't rely only on one cut. This was the message for this slide. Okay, this is at the end. This is the case. It's the same case. Now it's 20/20 vision now in this patient. But look at this. Look at the vessels here. The vessels. Be careful with the vessels. Look at the fovea is there. The fovea is here. But the vessels. Always look at the vessels. Let me show you this.
These are stiff vessels, right?
Huh?
These are stiff vessels that
yes,
cannot relax.
In the area of the staphyloma. Let me show you this case. Look at this. This was 2013, and I saw this patient for the first time, and was a big staphyloma, as you can see here. And after 4 years, she developed this. visual acuity went down 2063, and we decided to operate. Is there anything that I have to take care of this? With only I have enough, with the aspect of the foveal detachment and the schisis. Let me tell you the answer. Always look at the vessels, the temporal arcades. Okay, look at this. Look at this. This is the superior arcade you can see now, and this is the inferior arcade. You remember when I was talking about retinal detachment, you remember? And I told you, be careful in the vessels. Be careful in the areas of atrophy. This blue dye here is the dye entering in the retinal space, intraretinal space, not subretinal space. Look at this. Then look at this. There are vessels
in the retina,
all around.
inside the retina?
Inside the retina. Inside the retina. And when I doubt, look at the better flap there. And when I doubt, I always laser. And this is under discussion because you don't know if these are full thickness or only partial thickness. But if you have been there peeling the ILM or whatever, then I more comfortable, in this case with our definite breaks, I more comfortable to treat with laser. This is
so Dr. Mateo, you mean that
wow, it looks very nice.
Obvious cases could be due to micro holes? This foveus cases, this myopic foveus cases, could be due to micro holes around
No. This is a typical foveus cases. The micro holes, the only thing I want you to think about it is that around the arcades, you will find in many cases, kind of holes around the arteries of the veins. And then many of them are not full thickness. Many of them are partial thickness. But at the end, if you are treating this around and moving with the ILM and all this stuff, your traction may pull too much and then you create a hole. Okay? This is the aspect after the surgery. As you can see here, everything disappeared. And you see again in the vertical scan, you see the vessel. If you have a full thickness break, you are in trouble. Can you understand this? Then always look at your, the temporal arcades. Always.
Dr. Mateo, can you answer these questions? If you need to lasering in atrophic area, how to adjust the effect of laser? As you know, the effect was difficult.
Yeah, I know. It's difficult to titrate, okay?
Yeah.
I understand that. I understand that. But, when I see some change, then I stop it. I don't elevate more.
It's like an imaginary.
Yes. No, absolutely. No. You're right. And look at this. No. But you're fine. But look at the inferior arcade. You're seeing my pointer, right? You told me that you're seeing my pointer.
Yeah.
Okay. Look at this. There are pigment here.
That's the one.
There are pigment here. There are pigment here. There are pigment here. Okay? Then in these two arcades, I did laser in this case. If the arcade is very near here, I would stop it because the runoff phenomenon. You do laser here, and this laser can increase the size and affect the fovea. Then I stay around the arcade. I don't go too much further. Okay, do you understand this? Okay.
Yes.
So you need to tell us that the peeling of ILM in all myopic cases don't go away from the arcade. Yes.
Towards
will not go away from the arcade in peeling.
I think to the arcade is enough big. For example, in an emetropic macro hole, I always go this diameter only around the hole, no more. But in high myopes, you are looking two things. You're looking to put an inverted flap, for example, in other cases, and to increase the retinal elasticity. Because there are two rigid parts in the retina. One is the ILM, the other is the vessels. And you can see here, when you cross with the OCT, the vessels you see this spike, aspect of the OCT when you cross the vessels.
But
They
if you
stay
remove the
there.
ILM, if you remove the ILM from over these vessels, it will relax.
No,
Will not.
absolutely not.
So you don't reach them.
No, I arrived there, but the vessels
You
don't
stop there.
change. Yeah. Because when you move away from these arcades, it's so difficult to remove more ILM. It's so thin that you can promote breaks more than relax more, and you are not interested outside of the arcades because the staphyloma is inside the arcades. Then you are not interested there.
So you said you enlarge the ILM the first because of to relax the posterior pole, and the other to reach the vessel to
enlarge the staphyloma. Normally the staphyloma compresses near the vessels. Then I arrive to the vessels, and to go farther away to the vessels is much more difficult.
Okay.
Dr. Matteo agrees that autologous transplant is a good solution for large break inside the staphyloma in atrophic area.
I don't think
you mean which kind of graft?
Retinal autograft.
You're meaning the ILM, you're meaning the retina, or you're meaning the amniotic membrane?
Autologous retinal.
Well,
we know your.
Let's continue.
We know your opinion about that.
I don't know if Tamer is seeing this. Okay.
He knows about it.
He's a perfect surgeon and a wonderful friend. Okay, let's continue. Okay, look at this. This happened to me. This happened to me many years ago, and when I was performing, macular buckling in cases with schisis, and I went there. This is prior to the surgery. This after placing the buckle, this patient is 0.8 vision. 0.8 vision. 12 years later. But here in the arcade, in the upper arcade, look at this. There are some, laser, because I saw something, some breaks there. At the end, part of these breaks open, and the patient did a retinal detachment. Fortunately, due to the macular buckle, the retinal detachment didn't reach the fovea, and I could go again, and at the end I did more laser around the arcade, and I attached the retina. It remains the same. It's 0.8 vision, the only one eye. Then be careful. This is just to show you that it may happen. It may happen that these partial thickness holes, you can promote a full thickness holes, and be careful with the arcades. Always try to look your arcades. Okay, sometimes it's not that easy to differentiate between the ILM, the posterior hyaloid. Look at this. This is a case I had, some months ago, and as you will see now, I try to distinguish between them, but this is not that easy. Look at this. I started here thinking that it was the posterior hyaloid, but in fact was not only the posterior hyaloid, but the posterior hyaloid and the ILM. And now I'm going to show you one thing that you will find in some cases. This is the posterior hyaloid. Look at this.
You are under fluid here, Dr. Matteo.
Excuse me?
You are under fluid in this case.
Yes, under fluid. Yes. Under fluid. But I wanted to show you this, the posterior hyaloid. In this temporal area, inadvertently, I removed the ILM. I didn't notice at that time. But look at this. Oh, excuse me.
So this feeling causing breaks?
Excuse me?
The peripheral attachment here is causing a break?
No breaks here. This is only a traction, macro attraction maculopathy. But trying to distinguish
thickened posterior hyaloid or
attached to the internal limiting membrane. Sometimes you cannot remove first the posterior hyaloid, then the ILM. Sometimes you remove everything. Then be careful to cross the fovea. And this patient didn't have anything. But just to show you that you cannot control things as much in all cases. Look at this. This is everything. This is posterior hyaloid and the ILM. But look at this. I wanted to show you this. You can see these vessels now.
Yes.
you will see
Yes.
these vessels in many high myopes. In many, you have some vessels that enter, go, and they attach to the posterior hyaloid, and when you are peeling this, you will have some bleeding. Then be
Are
careful
those
with these vessels.
schitic vessels or what?
I don't know what they are, but I saw them in many cases.
When I see these, I sometimes face this situation. I always imagine that I am removing actually
The vessel of the retina. No, I don't think so.
yes, the nerve fiber layer. Sometimes I get scared.
Yeah.
Is this
I
is
thought
this a possibility?
I thought the same. I thought the same. But
So is this a possibility even or not?
no. But if you remove the nerve fiber layer, this patient will have a central scotoma. Terrible central scotoma.
I did have once. I
Oh,
removed
really?
it was an retinal membrane in a high myope, and she had also an artisan lens. I removed the ILM or the retinal membrane with the ILM, and it was so easy. But the next day she told me, and in the post-op period, she told me that she has a scotoma at this area, and she didn't have before. So I did an OCT. There was stained retina, but I could see some nerve fiber layer. So what happened in this case?
I don't know. Maybe many things. Maybe many things attach. I don't know.
Staining,
I really don't know.
Toxicity from stain. Maybe a
Well,
possibility.
I'm not going to show you this case, but I had one case, high myop case, macro hole with a vision of 20/50. I'm showing you in this case all over the world to see if there are other cases like this. I put brilliant blue only, not triple blue, and I removed the ILM. I put in the flap. Everything was perfect. I stayed 3 times just to be sure that I removed the ILM perfectly and the inverted flap. And he developed so huge, RPE lesion in not only the posterior pole, but also in periphery. That was terrible. I never saw that before. I'm going to try to publish this just to, but I don't know the reason. Cannot be, cannot be phototoxicity because there are places where the light is not there. Brilliant blue is defined as good. I don't. Excuse me. I stop this.
But you don't think there's a possibility that we can remove the nerve fiber layer?
No. I thought the same as you mentioned. I thought the same, but I never saw it.
You're putting my mind to rest now because I'm always thinking.
Yeah. No. I understand because I thought the same. But this is the aspect. This is 1 week because this patient was operated very, very 2 weeks or 3 weeks ago. Okay, let me show you this. And I was in a meeting, in a very known meeting 1.5 years ago, doing live surgery. And I had a case similar to this with a foveal detachment, and I did my surgery. And my question to you is: this is no macro hole. This is only a detachment in a patient with posterior staphyloma. There is no holes there. And I did my surgery. Look at this. There's a traction, and one surgeon, very non-surgeon, they answer. Okay, I do a retinotomy and remove the fluid. And I said, okay, be careful with the staphyloma because again, you remove the ILM, you remove the posterior hyaloid, but at the end, you have the staphyloma. Then any break here may
a problem.
Yeah, but in this case, you always think one thing, and suddenly you think perhaps you are wrong. Then you have to remove it. And then I did the surgery of this patient, multifocal IOL. I did the surgery, as you can see here.
Multifocal IOL for this high myopia?
Yeah, yeah. Don't tell me. I didn't do it. I find, yeah. Okay, then, look at this. This is
the macular buckle here, sir? Macular buckle?
No. I stopped macular buckle for these cases some years ago. Okay, then this is a special spatula that Cal O, described with an aspiration. This is the posterior hyaloid. This is not the ILM. Okay, then I began to remove everything, and then the ILM, as you can see here. Then I grab my forceps that was faster. Again, don't cross the center of the fovea. Always go in, never go out. As you can see here.
What is the kind of your ILM forceps?
I always use the same. I always use the same. I use this is from Bausch and Lomb. This is
Synergetics?
engripping. The engripping forceps.
Just in the grip. Okay.
23 gauge is not the same in 25. They say the same, but it's not the same architecture. This is for 20. No, it's not the same. In 25, the same end gripping of Bausch and Lomb is not as good for me.
Now you are peeling without using the BFO, so you are.
Yes. I there is no break here. There is no break.
So in this kind of case, I would have put PFC to see if there is a small tiny break in the posterior port.
No, but there is no break here. There is no break.
Are you sure?
No, I'm sure.
Okay.
Of course, I'm sure. This is a typical schisis with traction. Dot. No macular hole. No, I scan with the optic disc and everything. Okay. Then I trim the ILM, leaving there the ILM, but I decided, okay, perhaps my good friend from other country has right, and perhaps I can do a break here and no problem. And then I said, okay, where is the retina thicker? The retina is thicker near the optic disc. So look at this. I put some perfluorocarbon liquid now to aspirate the fluid. Okay, and I went near the optic disc. Not exact in the papillary macular bundle, not in the same line, but it's a thicker retina there, and I began to aspirate, okay, and under perfluorocarbon liquid, as you mentioned, okay. Then I ended like this, wonderful, and then I remove my perfluorocarbon liquid, and then I put some gas in, as you can see here, and this is the aspect. This is the aspect, 10 days later. You can see some fluid remaining, the retina attached, the bubble is here, and don't do it again. Don't make any break in the staphyloma. Not in the optic disc, not down, not tab. This is later on, okay? And I did laser around it. And then I came again, look at this. This is the aspect, 3 weeks after, later the previous picture.
I'm a big fan for active aspiration of schitic cavity, Dr. Matteo, by the way.
Yeah.
I'm not telling you this now.
And then I had to reoperate the case, and at the end I put silicone oil as my friend Ahmed, recommend me.
So the silicone oil in these type of cases, will it be tamponating this deep staphyloma?
Yes, I think so.
It will be tamponating it.
Yeah.
It will be conforming to this deep dive.
Yeah. This idea of conforming or not conforming the posterior staphyloma comes from very old times. Very old times. I remember an Indian poster in the American Academy that they were saying this. My friend TP Das from Hyderabad, and at the end now we know by far better than before. Then we feel the eye better than before. We peel the ILM and the posterior hyaloid better than before. And I think in these cases you can put silicone oil and you will have a wonderful contour. Look at this steep staphyloma that patient have. These are very steep staphyloma. Yeah.
Dr. Matteo, I need to get from you a clear message about MTM surgeries. Just an MTM, whatever MTM only or MTM with a large schitic myopic schisis like you are showing. Just peel the ILM over the fovea and keep the patient on gas. I'm right?
Then just peel the ILM, avoiding to cross the center. And I know there are papers that say that don't care. The only thing that need these papers perhaps is more cases. But If you have a
we need
macro hole,
the numbers.
you're done.
So you peel in, not peel out. Don't cross the fovea.
Don't
Put
cross the
patient
fovea.
on gas. Put the patient
You
on
leave
gas.
1 this diameter from the center, you leave there, you trim it, and you limit it. That's done. And you leave it there.
Leave it.
Okay.
Whatever the stage of MTM, whatever the stage of the sciatic cavity, whatever. Once you don't have a hole, you just peel in and don't cross and leave the patient on gas. This is a clear
Absolutely.
message. Yes?
Absolutely. Here the discussion would be, do you leave air or gas, or do you leave under the fluid because there is no break? Let me tell you my truth. My truth is I leave with gas. Okay, but I can discuss it, because the others would say, okay, but why? There is no break. Okay, I try to push the fluid away from the fovea. Okay, this is the only reason I leave this bubble of gas. But I understand that there is no break. You don't need it, because at the end will be the RP who will pump out this subretinal fluid.
And why Dr. Mateo, you stopped using macular buckle?
Because now, I started macular buckles in 2004, and I started in macular hole with schisis, and we are going to continue the next case. Then I began to use it in schisis to avoid full thickness macular holes after the surgery. You remember that when I started, the macular hole after the surgery in some series was between 20 and 27%. And I saw cases, and was crazy. It was crazy. Then because of this, I started macular buckling. But now we know how to avoid macular holes. We know how to distinguish between the posterior highlight and the ILM. We know how to avoid breaks. We know many more things. Then now the risk to have a macular hole after this kind of surgery is very, very low if you don't cross the fovea, of course. But I had one case in the last 4 years or 5 years. Then has no sense for me now. In macula, in isolated schisis with or without foveal detachment, I don't use macular buckets now.
Now, Dr. Mateo, we see more and do more.
Yes, no, we see more and we do better.
We do better. Yes.
So,
But
you still do the macular buckles,
Yes.
with the macular holes,
Retinal
right?
detachment macular hole. Yes. Well, I was invited in the World Congress, this weekend, and they asked me to speak against, the macular buckles, but the macular buckle in retinal detachment macular hole. But I still use them. Yeah.
Okay.
Let me show you this case.
Okay.
Let me show you this case. Do you want to see this case? Okay.
Yes.
Yes.
Okay.
Yes.
Look at this. Once upon a time, this was in 2010. And this 57-years-old female with had myopia in both eyes. Actually, it was more than 31 millimeters. And in 2001, phaco in IOL in both eyes. Okay? Then in 2007, the patient was operated elsewhere in other place, and you see the left eye was 2400 plus, but the macular hole still was still open. Then I saw no. In the right eye in 2007, the patient had this macular hole, and the patient refused surgery. In 2010, the patient had the macular hole in the left eye and was treated elsewhere, and you failed. And the patient came to me in 2010, okay, with this aspect. Right eye 20/100, left eye 20/400. And then this is the measurements of the macular holes: 675 microns in the right eye, 541 microns in the operated previously eye. Okay, my question to you is, because this is the aspect of the ocular fundus, and my question to you is, what would you recommend the patient?
I will start
One
to do the
eye?
surgery.
One eye, yeah. Which eye? First eye, right eye, 2007 macular hole. Left eye, 2010 macular hole, and was not
Failed.
closed.
I will
Which
start
eye?
with the right eye.
You will start with the right eye, okay? I told the patient to start to the right eye, but the patient...
The right eye, the better eye.
At
That's the
that
better
time,
eye, right?
yes, was the better eye, yeah.
The better eye.
But the patient refused any treatment. This was 2010. The patient came again in 2017, 7 years later, with this. You know, this is the aspect, as you can see here, 712 microns. And then I did, as I mentioned before, you know, at that time, I did with the AJL macroarbuckle. And as you can see here, we're placing the matter sutures. You know, you can find videos of this in the internet. This is the, here you can see the muscle, the infratemporal, supratemporal. I did my vitrectomy, as you can see here. Then I put perfluorocarbon liquid. Look at this. This is one of these kind of cases that you have retinal detachment to the periphery, and then I put perfluorocarbon liquid, and then I do a small retinotomy in the upper part, and then I will laser later on. Okay. Then the retina is attached, as you can see here, and then we are going to stain, as I mentioned before, under perfluorocarbon liquid. I was doing this because I was recording this. Normally I do it with the contact lens that you see better, okay?
Yes.
Okay, then you see here mixed ILM, you know, posterior hyaloid cells, membranes, and everything. And then I did my inverted flap, as you will see now. I put all of this over the hole, but this is so large that you don't put over the hole. You put just inside the hole because it's so large. But, you know, I did it, and, you know, I didn't press down, and I continue to remove. Look at this. This is posterior hyaloid. This is not interlimited membrane. Then this is interlimited membrane. And then you have to, distinguish between them. Okay, I enlarge as much as possible, you know, the peeling of the interlimited membranes. You can see here that this is a contact lens. This is the AJL. This is the buckle I use now. I put a light. I was the first to publish, to put a light within macroarbuckling, and then I did the same with this AJL macroarbuckle. As you can see, we are putting through this matrix suture now with the light, and then we fix with the suture, as you will see now. And then we are going to turn on and turn off the light just to see where the platform is. This is a great thing. You look at this. Too much in, and then I'm going to remove a little bit. Well, you have to, you know, move a little bit, and then you put it again to nasal, then you move it to temporal, and then at the end you put it in the right place, as you can see here, and then I put it right. Then at the end I was able to. This is the laser for the peripheral break, and at the end you suture everything, and this is the aspect of the surgery. And I show you this image because, you know, in the meetings, I always see, you know, doctors showing the papers I published, and they, you know, showing this, you know, bulky, you know, tremendous indentation. Let me tell you, this is not true. This is not the real image. This is from Cirrus. Cirrus, in the 6 millimeters, they make that, you know, these are not proportion images. You know, in the 6 millimeters scan, you have to reduce the height to the half. And in 9 millimeters, you have to reduce the height to 1/3 to have the real image. Cirrus, from size, they don't have the possibility to put in proportional way. The image of this patient in proportional way is, let me show you this.
Talking about the this is the OptoView.
This is one. So it is not as much indented as we saw.
Yeah, because the upper part is not the real image. This is how it comes from the Cirrus, but you have to know
because of the axial resolution. The axial
Yes.
resolution of the
No, it doesn't depend the axial resolution. They try to increase it, separating the layers.
Yes.
And then you can see better the layers of the retina better than this because are more separated. But if you want to have the real image of the 9 millimeters, you have to reduce this 1/3. And this is the real image. Okay?
Why you do a specific answer why you do buckle in this case, as you peel perfect ILM, and why you put the buckle in this case?
This is a good question. Why now I'm still doing buckles? I'm still doing buckles in cases where the posterior staphyloma is very steep. Okay, there are different
not
cases.
in this type of cases. Not in this case.
No. This case have a steep staphyloma. Let me show you this. Let me show you.
It's not that steep.
No. Yes. No. No, this is not. I have to show you. This is only the macular area.
Okay.
Let me try to find it, because I don't have here the longer OCT. But this is a look at when she was detached. Let me show you this. Let me show you the staphyloma now. You see it?
Yes.
This is very profound staphyloma. This is very steep staphyloma. It's not that flat. If you put a scan of 3 millimeters, you won't see the staphyloma. Then if you put a 12 millimeters, you will see how steep it is. Okay? Then it was really a steep staphyloma. It was not a flat staphyloma. Okay, then. Let me continue with this.
To know a clear indication for the macular buckle, only if we have macular hole detachment with deep staphyloma.
Yes, now is the way I'm doing now. If you don't have these so deep staphylomas, then I don't place the buckle. But let me show you more things.
Okay.
Look at this. Then what is the next? This is the other eye. Could you operate in the other eye? Why it failed? Why did it fail? Why? Why did it fail?
Because there is an even steeper staphyloma around the disc, I think.
Yes, but look at not in the macular area. And second, this patient has no retinal detachment. Then if there's no retinal detachment, I don't consider in this macular hole without schisis, I don't consider macular buckles. Okay? But my question to you is, why did it fail? Let me answer.
Because he didn't.
The ILM
was there. The ILM was there. Let me show you. Look at this. Staining, but look at this. So difficult. When the patient has been previously treated, it's so difficult to remove the ILM. It's so compact, to remove the ILM. At the end, I put all of the ILM inside the hole.
Why is that, do you think? Why is that? If the patient was operated before, the ILM is so difficult to remove?
Because they didn't remove the ILM. They remove,
Why it becomes difficult in the second time?
Excuse me?
Why do you think it becomes difficult?
I don't know, but all the cases that I had to reoperate from other doctors that they did the first surgery, I always find very difficult to remove the ILM. Always find very difficult. I find very difficult. Yeah.
Could be inflammatory process or something like this.
Yes.
I don't know. But believe me, if I had to reoperate them, you will find how difficult it is to peel it.
Yes.
This is the evolution of the patient. Look at this, 2010. Look at this, 2100, 2400. When the patient detached, and at the end, this is 0.8 now. Yeah, it's 0.8 the right eye, and 2063 is 0.3 the left.
Does he feel any metamorphopsia?
No, not in this case. In some cases they have. Yeah, so in some cases they have.
Perfect.
Your advice? What's your advice? Look at this. It's a macular hole, not previously treated, and 579 microns. Deep staphyloma, and then you know how to peel it.
No previous surgery.
Excuse me?
No previous surgery.
Excuse me?
No previous surgery?
No previous surgery. No previous surgery.
No previous surgery.
This is only one eye, but no previous surgery. And let me my answer.
I will go for.
Would you operate? Of course.
Yes. Of course.
Yes.
And I said no.
Why?
Let me show you why. You see why? Look at the optic disc. Look at the visual field. Okay? Let me tell you, this is the worst mistake I ever done in high myopia is not to look carefully to the optic disc. Then in these kind of patients, I always, and this was one of this, I always send the patient to my glaucoma specialist. And I ask them, can I operate this patient, or do you think that I will do it worse?
All high myopic cases, you are
Yes.
consult glaucoma consultant?
Yes. No. All high myopic, where I see this optic disc so pale, so excavated, then normally we do visual field, and I ask my colleagues I can do it or not.
But you tell us about the cases like this with a macular hole only. But if there is a detachment, no rule for postponement.
No. If there is a detachment, you have to operate on them because you will lose all vision the same. But for a macular hole, this patient has a visual acuity of 0.2 or something like this. Then if you treat this and it has a hypertension or whatever, you can have worse vision than before. You can turn off the unique light they have. Then my advice in these cases, always take a look on the optic nerve. Always. Because you can close the hole and the patient say, I can see nothing.
We will achieve success. Yes, we will achieve anatomical success.
I lost it.
We will achieve only anatomical success without
Absolutely.
any.
No. You will achieve anatomical success, but the patient will be very angry.
Yes.
Very angry. Because he will lose vision, really. Okay?
Yes.
Very nice.
Okay, let me show you this one. Then about this discussion about the buckles and no buckles, because there are many people that are telling me, you don't need buckles, you don't need buckles, you don't need buckles. Okay, then this is the first case 2 years ago, and I decided not to do buckles in patients with macular hole with schisis. That was one of my main indications of macular buckles. This 49 years old female, high myopia, posterior staphyloma, more than 2.4, as you can see here, and she was sent to me to do macular buckling and vitrectomy. And I convinced the patient. I say, okay, I have friends in Egypt that tell me that you don't have to use buckles, but you don't need it. And then, okay, I said, okay,
we are all your friends in Egypt.
There are many friends in Egypt. Okay, then this is the aspect of the patient, and I decided to go there, and I started my surgery. And I started with vitrectomy, as you can see here. Nothing happened. And then I went there. I removed the ILM. Look at the extraction of the posterior hyaloid. No problem at all. And then, as you can see here, let's go a little bit. Then I stain, as you can see, with brilliant blue in this case. And then, look at this. I removed the posterior hyaloid. This is not the ILM again. Okay, remove. And then I went there because some surgeons say that, look at the hole. Some surgeons say, if you remove the fluid inside the hole, you increase the possibility to close the hole. And I say, okay, let's try. 41 gauge cannula, and with my contact lens, as you will see, I remove it. Okay, this is the posterior hyaloid again. Let me show. Okay, this is the posterior hyaloid. I don't know. I'm removing this, and then I, and then my question to you is: Do you try in macular traction maculopathy to remove the posterior hyaloid that was removing to the periphery? You try to do this as complete vitrectomy in these cases?
I will try,
but I usually fail. I usually stop at the mid periphery and the retina. It will show traction, too much traction that I'm afraid I would do breaks. So I stop.
Exactly, I stop in the mid periphery because I don't want to produce breaks. Then I stain with brilliant blue, as you can see here, and we are removing the brilliant blue now. Okay, you see now the ILM. Clearly, this is the ILM. And then I started to peel the ILM. I normally start in the inferior quadrant, and I'm going to promote this superior to inferior, flap, as you will see now. Then I'm around the hole, as you can see, and then this is the flap, superior to inferior flap, because my patients leave the OR walking. Then I prefer this superior to inferior flap. You can see the flap now, okay? And then I put it there. I don't press down. I know it's not seen because the microscope was a little, disintegrated. But I don't press down. I put the flap and nothing more. Okay. Then, would anyone do something more? Or I told you before. I enter in the before peeling the ILM. I wanted to.
Yes, before peeling the ILM or after?
Yeah. No, it's before. You can see the ILM there. And I did it because some surgeons say that if you do it, it would be perfect. Then I remove the ILM as I show you. I trim the ILM. Excuse me, I did this.
But it's not a mandatory step to aspirate by 41 gauge, Dr. Mateo, yes?
No. Look at the aspect. No, it's not mandatory. I did it because some surgeons say that it's great. They say, okay, look at this. This is wonderful. This is wonderful ILM flap. I mean, inverted flap, but the macro hole was open. Okay. Then, why did it fail? Because I removed the ILM. I put the inverted flap. The inverted flap was there. But, why did it fail?
Because the flap is being reopened again.
The flap is? What? The flap is?
Reopened again.
Reopened
again, not...
No. The flap was there.
Unfolded again.
No. The flap was there. No. The flap was there. This is the flap. The flap is covering all the hole. The flap was there. Then, and then in this case, I did a macrobuccal, and as you can see here, we opened the supratemporal quadrants, as you can see here. Then we place again with, all of this. And then I went there to see if my friend Tarek has right or not. And I went there and looked at the flap. The flap was there. No problem. And I began to touch the flap. And I began to touch too much the flap. And at the end, I broke the flap. And then I didn't have flap. And then, the flap floats. And then it went, over the bubble. And then, it was so difficult to put the flap again. Then I had to go with two, finesse loops to put the flap inside. Then at the end, I was lucky, and I pushed this flap over the hole, as you can see here. And then I'm going to put the flap over the hole. That's perfect. And then I put it inside in this case. And I put the as you can see, I was perfectly centered. Look at the blue dot ILM plaque was present. But at the end, when I removed the remaining fluid, the blue tag disappeared. You will see now.
And you left it on gas, huh?
Yeah, I left it on gas, yeah. The blue dot absent. And the answer is, it closed. Then macrobuccal makes something. We can discuss about it.
It's totally because of the macrobuccal. Nothing.
I don't know. The flap disappeared. The flap disappeared. No ILM there.
It's obviously not there.
Yeah. Then but let me tell you, the history continues, and I continue the history. But after this first case that you see upper left, I started, see the second case is the case I showed you before. The third case, the fourth case, the fifth case, the sixth case, seventh case, and the eighth case. Look at this. Look at this. This patient has a very good visual acuity, but the macro hole is open. But this is 2032 vision. Was 32 before, and is 2032 vision. But it remains like this. You can see the flap, and you can see the hole. And yes, today, I saw my last patient. This is my last patient. This was 3 weeks ago. And, I'm making this series of cases just to know if I'm right with the macrobuccal or I'm wrong with the macrobuccal. And this patient came, 5 hours ago. What do you expect of this? What do you expect?
It is closed. It is opened. No.
It's open.
It is without. It is
Perfect
without.
flap. Perfect flap, covering totally the hole, the hole, but the macro hole is open. Then next
No
step will
buckle,
be
right?
no buckle.
No.
No, the next step will be buckle design. Yeah.
So we need to rise up again the rule of macular buckle in
I think
MCM.
so. I think so. But the problem of
You don't-
macro buckles is that one is not easy to perform. I did more than let's say 350 buckles in my life. I'm used to it, but it's not that easy. It's not that easy. And then
and you don't want to give the free flaps a chance.
It's a good question. Try first with the free flap, and if doesn't close, then use the buckle. Okay, from the first case would be the right way, but when you fail, the macro hole over time tends to open more. When this was published by Ikuno and Tano many years ago, and then I'm afraid that if I wait more, too much, then you can end with a larger macro hole. And I had some cases here, but this is the transplant. Yeah, tell me.
No. I'm afraid that we are too
Sure.
much long time for you.
Sure.
No.
If you're not tired, we're open to a stay for longer time. If you're okay with that,
the last slide was this slide was for the really big macro holes I was showing, but you have been many I've seen many videos there in your country showing the how to fix this with the technique of Tamer Mahmoud. This is a great thing, with these big macro holes. I only use this for big macro holes, as you can see here.
what do you do?
This is a retinal transplant. Transplant.
Oh,
But you have seen this many times, and you put the flap inside the hole and all of this stuff. You
did give it a chance
to see it.
You tried it. You tried it, right?
Yeah.
I tried many times. Yeah.
Yes,
I tried many times.
And you use it in this kind of big macular holes.
Only big macro hole, big macro holes. Look at this. Let me show you. This is how it closes. When I explain big macro holes, look at this. This hole, for example, and this hole, for example. This is a terrible one. Let me show you this one. This is a terrible. Look at this. This is not only one break, but there's a huge hole. This I put a piece of retina. Yes.
Disc diameter. It's a disc
diameter. This diameter is larger than the optic disc.
Oh.
And there was not only one, but this is only more than one hole. It was the macro hole, big, and around there were more holes, and I covered with this. And the patient is happy because the retina is attached. Then you increase some vision in these cases because you attach to retina, and then but they in my cases they don't fix in the hole. And then my case to you is this one. This is not a high myop. This is just for you to relax. Okay. Yeah. This is a patient I had 4 months ago, and this is a high myop. This is a 8 diopters. He has as you can see here, an EVI, and has a luxation of the intraocular lens. My question to you is, how do you manage these cases? You have this lens, 3 pieces lens, and how you manage this? What's your technique for this?
I catch it from the optic junction and try to catch it from the haptic, the optic if it's 3 piece, and I elevate it to the pupil level. Then I take it from the other side, from the anterior chamber by another 20 gauge forceps, and take it by head check technique.
Okay. Okay, then your answer is you remove this lens.
Yes.
Is correct?
Yes.
Is there anybody of you that you try to preserve these lenses? Try to,
Today morning I
Yes,
tried
if
to
it-
preserve this lens. This is what happened to me in the morning. Today, I faced this situation and I try to save this lens as much as I can, but I fail.
if there is capsular support, I would try
no
to.
capsule support, no capsule support. The
Okay.
Oh,
capsule,
Yamani technique.
the support, the only support of the capsule is here.
Yes,
You have no more.
Okay, you can put it as a
Scale
biomagnetic technique.
fixation. Scale
Or
fixation Yamani technique.
Yamani
Oh,
technique.
Okay, then my
Yamani.
my preference always is try to preserve the lens. Just to avoid to open, just to avoid to have choroidals, hemorrhages, and I always try to preserve. Rehabilitation is much better, and I always try to, and then for these 3-piece lenses, I use the Yamani technique. Okay, but the problem is
But you do
it
it in
doesn't
reverse.
end like this, huh?
You do it in reverse. You take
Yes.
the
Yes, my friend.
Trailing
Yes.
is good.
Yes,
Ah.
absolutely. Well, no, it's not the trailing. It's the optic that is facing to you. It is by far better. Believe me, by far better.
it is the more difficult one.
Exactly, my friend. Exactly, and it's when the lens is more free. Then you put it in the more difficult, and then you take it out, and then down is by far more easy to put
Yes.
in the
Ah,
syringe. Then
that's a clever idea.
begin first in the upper, not in the down. Okay. Okay, then, but the problem is has not ended here. This
Look
patient.
to the bend of the needle. The bend of the needle is a 90 degree. I say, I'm right. You bend the needle at 90 degree.
Yeah, more or less 90 degree. Yeah. But Yamane, if you want to enter in the Yamane problems, let me tell you, for me the problem of the Yamane technique is that we always say we create a perfect tunnel. This is not true. This is not true, my friends. Look at this. Look at this. Look at this. Look at this. I mark it. It's not seen in the video. I make a mark here. From here to here, but and I put the syringe here. But at the end, you have to gyrate, to turn, the syringe just to see the optic, the optical part. Then you are breaking the tunnel. In fact, can you understand what I'm saying? Then you are not creating. You are not creating.
Yes. The tunnel is a mess. Yes.
This is we do it, but oh no. We do it, but this is not true. It's not true. Look at this. Now you go to the inferior. This is the superior as mentioned.
I do it with the trocar. With the 25
well,
beats.
The trocar is not bad. Look at this. I make a tunnel, perfect tunnel. Then you have to gyrate. You to put the optic inside. Then you are not creating. Well, the problem is that this patient is a treatment for prostate hyperplasia. And he has one problem, that is floppy iris.
Yes.
And then, the picture seems perfect, and, it's perfect, a little bit tilted, but, it's not that bad. But, with this reconstruction, it's a little bit more tilted than I expected. And I think that tilting in the Yamane is not really solved. And at the end, the patient did like this. And in the office, I could put it down, and after 5 minutes came again. And I put it down, and after 5 minutes came again. Then, now what are you going to do? What's your next step?
Push it
I
down.
remove
Of course, to remove the lens, right? You remove the lens. Okay, and use what other lens you use after removing this one?
We use the iris claw.
You use the iris claw. Okay.
Yeah.
Okay. Then, it's not the answer. Oh my God! Don't tell me this.
The answer is not
the answer.
here.
Excuse me.
Please, Dr. Mateo, give us.
No, I wanted to show you the Carnevale lens. Oh my
We need
gosh.
the answer.
Okay, let me show you because I think it's a nice. Let me. I do it in 1 moment. If you leave me 1 moment, I give you 1 moment.
What you
Let
Oh,
me.
okay.
Let me 1 moment. Definitely Retina Cafe. I think Retina Cafe. I have so many videos and it's a crazy thing.
We have a folder in
It's
your
a
laptop
crazy
called
thing.
Retina Cafe.
Yeah. It's not
We
here.
have to send the spy. We have to send
Yeah.
the spy to copy it all.
Oh my God, it's not here. I'm so sorry, my friends. It's
No
not
problem.
here. Let me try to find it here. Where is Retina Cafe here? Was it's not here.
You can
I'm so
write
sorry.
it in the search. You can write it in the search, Dr. Mateo. Just write
Like
it in
what?
the search. Retina Cafe.
Yeah, but no, it's not. The video is not here. I don't know why it's not here.
Yeah, قصدي you can go to the search and write Retina Cafe and it will appear and just in the search upper right, far upper right.
Oh yeah. No, yeah. But the problem is that no. I find it. Oh, no, don't worry. I find it. But the problem is that I don't find
The
where
video.
is my video. The second part of the video is not here. I'm so sorry.
Okay. No problem.
I'm
No
so
problem.
sorry.
So
I'm
what did
so
you do?
sorry.
What
No,
did
I
you
put
do?
a Carnevale lens.
What?
Carnevale lens. This is a new
The
lens.
perfect lens.
This is
The
a
perfect lens.
crazy good lens. Let me try this. Wait a moment.
But this lens is only in
I
Europe.
have
It
it.
didn't.
I
It's
have it.
only in
Yes.
Europe. Yeah,
Yes.
It's only in Europe.
I have
The
it.
menu is perfect, by the way. I don't know what happened.
Okay,
This
let
is
me
about
let me
iPhone.
try to share this. Let me
Okay.
try to share this. Wait a moment. I'm trying to share this. Oh, so complex.
Yeah.
Don't stop screen sharing.
You have a treasure in your laptop.
You
want to steal it.
I have 3 screens here, my friend. 3 screens. Okay. And now I have to share my screen now and try to share my screen, share screen, and but where is my you see something? No.
No, still nothing.
You don't see it, right? No, I cannot do it. Okay, let me half of a minute. I put it there and I show you, and that's done. Okay, I'm so sorry. I was convinced that it was done.
Your time, Dr.
We're
Mateo.
so happy with you. We're so happy with you.
Yeah. So
We're
sorry.
enjoying so much.
It's 1 minute. It's 1 minute. It's only 1 minute. Only 1 minute.
The special lens, I saw it.
You don't know this kind of lens?
I know
No.
it. I know it once, bro. I know it once, but it's
What's
a very
its- what's
special
its
lens.
name?
It's not available in our
It's,
country.
it's a nice. It's very nice. It's very
What's
nice.
it- what's it
Artisan is
called?
very nice.
What is it
It's
called?
Carnevale lens.
Carnevale.
Carnival?
Carnevale, yes.
Carnevale.
Carnevale, selecciona la pantalla de Retina Café. I think it's this one. Okay, and is this one, I think. Okay,
Yes.
and then is this one? Are you right?
Yes. Until now,
Do you see it?
we see the folder, only the folder, and not the video.
Then it's not here. Then wait a minute, and then let me try to stop the screen, and again, screen share. The problem is how to find which screen I want to share. And then this is the place, yes.
وائل الجندي بيقول لك انه شافها.
Mhm.
Somebody told while you were searching.
What?
لا هو نعم خلص. Open it يا دكتور ماتيو. Open it now. You can
And
open
now,
it now.
is this one?
No, it's just a black screen. You can do it like this, like you are doing the. It's just a screen share.
Let last try.
We need it.
This is probably so many screens, I'm a crazy guy. Okay.
Carlo Carlevali.
No,
Yeah.
don't put it in a full screen. Don't put it in a full screen. Just it. Just to play it like this, not to play in a full screen. Just yes, you play.
You see it now? But you see it?
Yes.
Okay, perfect. Okay, look at this. Then we open the conjunctiva thing that I don't like it too much, but look at the adherence of the Yamane. This is really, you need to make some force to remove from the tunnel. Look at this. This is the two of them. Okay, and then we put it there, and then you created. Let me show you a little bit better. You created two radial cuts, and you make some pockets. Two pockets. Then you will remove these
different
lens.
directions, pockets.
Yeah, to down and up. You will see why. Then you will see the Carlevale lens. This is the Carlevale lens. This is hydrophilic lens. So that has these harpoons, and then you open an incision 1.8 from the limbus, and then you remove one harpoon from here. Look, you see the harpoon here, and now we're going to the other side. Okay. And this is a big lens. This is 6.5. And look at this. You don't see the lens. And look at the harpoon, and then you make the harpoons inside the pockets. Okay.
بتبقى عامل vertical incision. You do vertical incision, and he have a horizontal haptics. So the horizontal haptics is stuck on a vertical incision.
Yes.
And covered by scleral flap.
Yeah.
No. In the
you do pockets.
In the red reflex, did I see some hemorrhage that took it down?
Yes, absolutely. If you look at this, if you look here, let me go to the video and going down a little bit. All the at the end I remove it. It's not seen in the video, but at the end I enter again. Yes. I enter again in the vitreous cavity and I clean it. I clean the. But if you look at here, you see some subretinal hemorrhage. Okay, because of this, I don't like to remove lenses from the eye. It happens sometimes.
You suture it. You suture it. I see.
No, you suture. No, you suture the vertical incisions just to avoid losing fluid from them.
So I see some surgeons doing like this. Do a lamellar vertical incision, just a lamellar, and go through the center of this incision by 30 gauge cannula or 27 gauge cannula syringe, and go through and pick up the haptic and just no suturing for this scleral tunnel.
Yeah, I think it's Carlo Carrevale recommends to suture.
I see it from Carlo Carrevale.
I think he recommends. I saw him in a meeting we had in Dubai meeting, and I suture it because I don't want to have hypotony the day after. Then I suture it. But if you don't want to suture, don't suture. But at the end, you enter. There is you leave a small quantity of sclera. I prefer to suture.
Okay.
And that's all, my friends. That's all I wanted to show you.
So amazing.
Yeah, amazing. Very long. This is almost 11. This is 3 hours.
We didn't feel it. It was very, very nice and very entertaining. Actually,
this is the idea of the cafe, Dr. Mateo. This is the idea of the cafe. You don't feel about time.
And also the idea of this of this cafe is that it is so different concepts, so different from what we are used to. But but we know that the world is bigger than us, and
Sure.
there are so many rights to and so many different ways to the same end.
Do things. Yeah, sure, sure.
And we're so
we have
and
to
we're
share
so happy,
experiences.
and we're so happy to have had you, the Dr. Matteo.
We really honored
very-
to have you between us, Dr. Matteo, today. We learned a
Yeah.
lot, and we learned a lot of
Happy.
tips and tricks. You are amazing as usual.
I'm happy if you find that you don't agree in anything, just write it to me. Just write it to me. We can share it and discuss this. This is no problem. This is my experience. This is not.
So this is a promise that you will join us once more, right?
Sure, absolutely, no problem, no problem.
Thank you.
No problem. With my friends.
It was
They are great friends. They are great friends. I love them.
yes.
And we thank COVID that give us this chance to be with us, Dr. Matteo, and we will see you again and again in our cafe. And can you show up your mug, please? Can you show up your mug, please?
With Anubis.
Anubis, yeah, I have it here.
Yes, this is an Egyptian one, okay?
Yes. It's Anubis
Yeah,
here.
the pharaonic with Anubis,
Steve.
the god of death.
Yeah, you have to be used to. You have to. When you get older, you have to think about it. Yeah.
Thank you so much.
All right. I need to summarize this episode, Dr. Matteo, that you are giving us one single point is a visualization, is a contact lens magnification. This is a big point of this.
You will definitely use it.
Yeah.
We will definitely use it.
Believe me. And then you compare your view and the result. That is a great system, great, but it's not comparable. So, believe me, the magnification, the stereopsis, everything. And you remove the result and you put it there, and that's done. It's great. Believe me. If you want to have very good videos and people say, oh my God, without no tremor and it's wonderful, do it without, because it's so because the macula is so small that you tremor.
It's not about the tremor, it's about the depth of focus. You feel like the macula is huge like this, and this is what I see.
You see the shadow that the bezel makes in the RPE. Believe me on that. Put in the light of the side, you see the shadow of the bezel. Believe me, the quality of the lens is amazing.
We will use it and record it, and we will tag you on the Facebook once.
Okay.
Tell us, Dr. Matteo, you have an experience with contact lens in a 3D heads up, or you don't have a 3D heads up in your?
We have. This is another topic.
Yes, it will be a good topic.
This is a big difference.
There are some impressive surgeons that they prefer to use heads up. That, let me tell you, I have it, but I don't use it. And we have it at IMO, but I don't use it. The cameras are wonderful, but let me only
The
two
depth
things.
of focus is so much more.
Perhaps it's this. I know, but let me tell you. When I'm operating, I only want to see one thing. What I'm saying, the macular area or whatever. I don't want to see the anesthesiologist. I don't want to see the nurse moving. I don't want to take one guy, clicking the machine just to, I don't want to see anything of this. And the quality of the system is
there's a
good.
VR set that you can use.
There is I tested, my friend. I tested, and the quality is not as good. Yeah. Do you know this? The Sony helmet? I tested, and the quality for me is not enough. And but the system is perfect. I think this perhaps is the future, but I need one thing. I need two sources of information to share. Okay, then when I have imagine that I have a camera inside the eye, or I have an OCT in my hand, not in the microscope, in my hand, to look for different places of the retina. There was a Nidec tried to have it and they stop it. But when we have two images to share at the same time, I think the system will increase.
Okay.
But now I don't see it. But perhaps I'm not good enough to see the advantages.
The
But
possibilities.
we don't use
No,
it.
the possibilities will be
I
great.
don't use it. I don't use it.
We will not make it long for you, and no word can express our happy for this episode, Dr. Matteo, and thanks for everything.
Thank you very much. It has been a pleasure to have you here
It
all
was a
of this
very
night.
nice night. Thank you.
Take care, my friends. Take
See you
care.
soon.
Thank you, Michael. See you
Bye.
soon.
See you soon.
Bye bye.
استني يا ولاد اخلص